Okay, so welcome to the discussion on the DAMS NEET PG mock. This mock is available free on the app. If you've given the mock on the app, and all you need to go is you go to the app, go to the online test series, and you will find the NEET PG mock in the unlocked section. It is going to be unlocked for you, and anybody who is not even a DAMS subscriber can give this test. So let me discuss the radiology questions from this mock. Let us see the first question. So this is the first question that I've given you, and I want you to understand that this is the style of the NEET PG exam. NEET PG exam usually uses short STEM clinical vignettes, and whenever a topper sees a clinical vignette, they are able to see the keywords. Keywords in this paper, if you look at it very carefully, will be crazy pavement. You are able to see a CT appearance called as crazy pavement, which is due to interlobus septal thickening and ground glass. So there is ground glass opacity as well as septal thickening, that is called as crazy pavement appearance. So crazy pavement appearance is a feature if you have a condition called as alveolar proteinosis, where due to macrophage dysfunction there is accumulation of surfactant like lipoprotein in the lung alveoli, and there is also septal thickening causing a crazy pavement like appearance. This appearance would look something like this. So you will have the interlobular septal thickening along with ground glass appearance. This is what is called as the crazy pavement appearance seen in alveolar proteinosis. You might be thinking, what about other choices? What is the finding that you will see in UIP? The finding that you will see will be basal subpleural honeycombing. Basal subpleural honeycombing and traction bronchiectasis. The keywords will be traction bronchiectasis and basal subpleural honeycombing. NSIP, what will be the keyword? Basal ground glass opacity, but the keyword will be subpleural sparing. Subpleural sparing. Okay, let's see the fourth choice. Cryptogenic organizing pneumonia. The keyword will be atoll sign or a reverse halo-like appearance. There will be an area of increased density or consolidation with central ground glass, which is called as the atoll sign. So these are the other choices in the paper, and this is a new question that we have created for you. To create, it can be asked as a one-liner also. In one-liner, I will directly ask crazy pavement appearances seen in. Here I am making a clinical vignette and I am trying to dissect all four choices. What is the most useful investigation for localizing of parathyroid adenoma? So you need to do a preoperative localization of parathyroid tumors. The answer will be sestamibi scan. You saw this question. This is one of my favorite questions because it is repeated multiple times in both NEET PG as well as INICET. It is a very, very important question, and I'm sure most of you got it right in the INICET recently. Any other question that I am expecting out of this is, can you tell me in which condition do we see brown tumors? Brown tumors are a feature of hyperparathyroidism. Okay, one more question. Subperiosteal resorption. Subperiosteal resorption of bone is a feature of hyperparathyroidism. And if they want to go a level higher, they will say Rugger Jersey spine is a feature of secondary hyperparathyroidism. Due to renal osteodystrophy, you find a Rugger Jersey spine. Very, very important question. And the third question I have kept for a image based question, short clinical history, short clinical STEM, 8 months history of diarrhea. This is the keyword. Something wrong with the bowel, and I am showing you a CT image. This is a coronal CT section. This is your descending colon, and a little bit of ascending colon is visible. Transverse colon is not seen because they might be in different planes. So in one section you may not be able to see the entire colon. So this is your descending colon, ascending colon. What is it that you appreciate? You can easily appreciate you can't see any haustray. There is reduced caliber of the colon and there are no haustray. So the entire of the colon, including the right side, looks like a lead pipe. You can see the lead pipe appearance of colon, ahaustral appearance. If you see a ahaustral appearance, then it is a sign of ulcerative colitis. Why not tuberculosis? Tuberculosis usually is diagnosed when you see a ileocecal involvement. So if the involvement was primarily cecal and ileal, then we'll say tuberculosis. Crohn's is again more common in small bowel, terminal ileum, you should see a string sign. And entire of the colon, pancolonic involvement, you can see there is almost the entire colon is involved, is unlikely to be seen in Crohn's disease. And so you will have skip involvement, string sign. These are the words that you look for in Crohn's. And comb sign, you will see the mesentery would have increased vascularity, which is called as the comb sign. Pseudomembranous colitis, the sign is called as the accordion sign. In this, the haustria are not lost, they are actually swollen. So creating those folds of accordion in the imagery. So CT appearance of pseudomembranous enterocolitis will be accordion sign. So I hope this gives you the perspective. This is the question that I based on last year's NEET PG paper. This is a patient who has gone on a ski vacation. So why would you go for, where would you go for ski? You will go to high altitude because you need snow-capped mountains to do the skiing. And when you are on a vacation, you are likely to be careless. So in your vacation, you will be a little careless. You don't acclimatize. If you don't go acclimatize, you go to high altitudes, you may develop a problem called as high altitude pulmonary edema. You look at the cardiac size. Look at the cardiac size in the X-ray. The cardiac size is normal. This is not say a heart failure because there is no cardiomegaly, and plus you see there is diffuse whiteness, there are diffuse opacities in the lung, and there is a history of high altitude. So this is a high altitude pulmonary edema, which is a variety of non-cardiac pulmonary edema that is visible here. You might be saying, sir, why not pneumonia? There's not even fever. Why would you say pneumonia if you don't even have fever? The heart is not enlarged. There's nothing to suggest about heart failure. There's no bat wing predominance, no curly B lines, and diffuse alveolar hemorrhage looks too specific a diagnosis to be made on a X-ray. X-ray पे ऐसा कैसे बोल पाओगे कि पानी भर गया है कि hemorrhage है? You can't say this. This looks too specific. This is one of the tricks you can use in your MCQs also. If it is too specific, you can actually rule it out. The answer is non-cardiac pulmonary edema. In the last NEET PG paper, there was a patient with pancreatitis who came with breathlessness, and you had to correlate that pancreatitis can lead to ARDS, and the answer was non-cardiac pulmonary edema in the last NEET PG as well. So that is the pattern I wanted to keep in my test paper. Last NEET PG again we had a similar question. Now I will show you a image and I'll ask you to make a connect. This is a new question but based on last NEET PG paper. You can see this entire of the shoulder joint is lost. You can see there is all the shoulder joint is lost, and there is a cavity in the spinal cord. There is syringomyelia, and the tonsil appears to herniate below the foramen magnum. So what is happening is you have a patient with carry 1 malformation with syringomyelia, which will lead to neuropathy, and the shoulder is showing that neuropathic joint changes. So you have that neuropathic joint changes on the X-ray with syringomyelia, with tonsillar herniation. These are all features of carry type 1 malformation. Otherwise, you would have been wondering why sir has added a X-ray and this here. So I'm trying to give you a connect the dots. This is the kind of paper we had last year in NEET PG where there were some questions with more than one images, and you had to connect the dot. For example, last year in NEET PG there was a question on Carter-Jenner with a sinus X-ray, bronchiectasis, and trying to give you a connect the dot kind of a system, situs inversus. But if you don't have the ability to understand why these two images, then you will have what is happening. Now you know why I have given you a shoulder X-ray and a MRI together, because this is carry 1 with syringomyelia with neuropathic changes in the joint. So I hope you are enjoying the NEET PG discussion, mock discussion here, and I will invite now the next faculty member to continue the discussion. Make sure that you attend the entire discussion on YouTube. This mock is available in your online test series in an unlocked fashion. Even if you're not a DAMS subscriber, you can give the paper and enjoy the discussion on YouTube. Reason we are putting it on YouTube is so that maximum students can benefit and maximum students can be kept, and we can help you to keep up your momentum. That is our goal now. We want to help you keep up your momentum till the exam date. Wish you all the best. Keep reminding yourself, अपना टाइम आएगा नहीं, अपना टाइम अपन खुद लाएगा.
So hi everyone, today we are going to talk about the obs and gynae questions that you came across in the NEET PG mock, and I hope that you've done well. It was of moderate difficulty, I would say, right? So let's look at what you need to know. So let's look at question 1 first. Which of the following surgical procedure would you do for the anomaly shown? And what can you see here? Do you see that when we are showing you a lap image, what does it mean? That we are also showing you the external contour. And do you see that there is a dip in the fundus, right? So there is one uterus here and one here, and there is a dip in the external contour. So if there is a dip in the external contour, then this anomaly can definitely not be septate uterus. It can also not be arcuate uterus, right? Because there is no dip. Also, you see two equal horns. Okay, so if you see two equal horns, this is also not likely to be unicornuate, which means this could either be bicornuate or it could be didelphius. Although this is more likely to be a bicornuate because we can see a single cervix. But yes, we need to know if there are two cervices, then it could be didelphius, but this one clearly is only a partial defect of fusion. Okay, so remember, hysteroscopic is what we do for septate uterus. This is not the answer. Mackendo is the name of the surgery we do for vaginoplasty. Kisme karte hain? We do this in androgen insensitivity syndrome as well as in Mullerian agenesis, right? Transcervical is not the answer again because that's another name for hysteroscopic. So what are we left with? We are left with Strassman metroplasty, which is the surgery we do for bicornuate uterus also and a didelphius uterus also. Remember that this is the unification surgery. Okay. Now, also some important things, investigation of choice for Mullerian anomalies. Kya hota hai batao? It is 3D ultrasound. Perfect. And what is the gold standard? It is MRI. And if I ask you what is the best investigation, if there is a doubt, then it will be a combination of laparoscopy plus hysteroscopy. And if we have to choose one, the single best would be lap. Remember, all Mullerian anomalies have high risk of urinary anomalies. But if we have to mark one, the risk is highest with unicornuate. So all these women must be evaluated for urinary tract anomalies. Okay. Chalo, let's look at the next question. So this woman is undergoing ovulation induction for IVF. There is distension, nausea and shortness of breath, and she has already received the HCG trigger. So what is the underlying pathophysiology or mechanism? So what do we see here? So we see big follicles in the ovary. So this is a stimulated ovary. In fact, such big follicles, this is actually a hyper-stimulated ovary, right? And which drugs are likely going to do such kind of a hyperstimulation? It is injection, HMG, human menopausal gonadotropin. So they are going to cause the hyperstimulated ovary. And then what happens? If we give the trigger, this will cause the ovarian hyperstimulation syndrome. So the syndrome is caused by HCG. How? So when you give trigger to this hyperstimulated ovary, it is going to release VEGF, right, which causes capillary injury and leaky capillaries. So this is because of the release of VEGF, which is the mediator, right? So there is going to be a capillary leak, and therefore you have to know that in ovarian hyperstimulation syndrome, you will come across hemoconcentration, you will come across third space fluid accumulation, for example ascites, for example pleural effusion, and you can also come across end organ damage, right? So there could be ARDS, there could be renal failure, and there could also be DIC, right? So eventually, yes, it can definitely be life-threatening as well. So very important. Please remember injection GnRH, whether it is agonist or antagonist. they are in fact used to reduce the risk. Okay, they reduce risk of OHSS. Apart from injection HMG, which carries a very high risk of OHSS, the other important risk factors for OHSS are PCOS and high AMH values, right? So if they are more than 3.3, we say there is a high risk of OHSS. Okay, chalo. Next, which of the following is the most common long-term complication of the condition shown below? So what do you see here? So let's look at the laparoscopic image. So this is the uterus. And what are these? This is actually the fallopian tube. And what do you see here? There is a constriction in the tube and then there is dilatation. So there is dilatation, constriction, again dilatation. Then what else do we see? We see a lot of adhesions in the pelvis. So what do you think this is? This is PID, right? So this is a laparoscopic image of a woman who has pelvic inflammatory disease, and the most common long-term complication is infertility. Okay, please remember Fitzhugh-Curtis number 1 is not the long-term complication. It can happen during the acute phase and it is seen in only up to 10% patients of PID. What exactly is Fitzhugh-Curtis? Yes, this is perihepatitis. It's not hepatitis, it is perihepatitis, right? Also remember ectopic pregnancy. Yes, that is also a long-term complication, but not the most common. So the order will be infertility, then the other complication can be ectopic, then it can be chronic pelvic pain, it could be hydrosalpinx formation, and it could also be recurrent attacks of PID. Okay, so there could be recurrent PID as well. Why is this not endometriosis? So number 1, in endometriosis, you don't see dilated tubes. You actually see probably big ovaries because of chocolate cyst. Okay, and secondly, in endometriosis, you will see very characteristic either powder burnt areas, right, which are bluish black white areas, or you will see red flame lesions along with a lot of adhesions, right? The history would be of chronic or progressive dysmenorrhea, right? That could be the history when we talk about endometriosis. All right, let's look at the next question. So your patient is in the 3rd trimester and when she is lying flat, her BP is going into hypotensive ranges. So yes, we are dealing with what? We are dealing with supine hypotension syndrome. And we are asking you, what is the cause of this syndrome? So is it compression of the aorta? No, it is mainly because of compression of the IVC. So what happens in pregnancy is that there is a fall in the diastolic blood pressure. There is also a fall in the systolic blood pressure, but diastole falls much more, right? On top of this, if the woman lies supine, there is compression of IVC by the big uterus. So the venous return decreases. The cardiac output will reduce and therefore it will go into, the BP goes into hypotensive ranges. What is the management? Please remember, supine hypotension syndrome is a physiological thing. So what do you do here? You are simply going to ask her to change the position to left lateral. Ask her not to avoid the supine position. Let's quickly look at the other physiological changes that you should know and we are fond of asking. There is a decrease in peripheral vascular resistance. Okay, because of the fall in blood pressure. Definitely, yes, there is an increase in cardiac output and heart rate, but peripheral vascular resistance is going to decrease. Okay, also there is a, please remember this, there is a decrease in the plasma osmolality as well as the oncotic pressure, right? So these are also going to decrease. So you also do see physiological edema. Then remember, there is a increase in TLC, increase in ESR and increase in all clotting factors, right? When I say all clotting factors, nothing in medical science is all. So except 11 and 13, which actually show a decrease. There will be a decrease in the platelet count from the pre-pregnancy value. So we very often come across gestational thrombocytopenia, which is actually very mild. Okay? So there is a decrease in the platelet count. So these are important changes in the circulatory system that we should know. Please remember, as far as the oxygen carrying capacity is concerned, it is going to increase. Also, there is a big gravid uterus, and you should remember that whenever we talk about reserve or residual volumes, they are going to decrease. ठीक है, चलो आगे बढ़ते हैं. Which of the following is contraindication for performing a dilatation and curettage? Then the best answer is perforation. Obviously, if you are suspecting a perforation, we are not going to do a DNC, right? Now, apart from this, what are other important contraindications of DNC? So you should know we will never do a DNC if we are thinking of a pregnancy. Okay, unless it is a complicated pregnancy like missed abortion or an incomplete abortion. So when there is a live intrauterine pregnancy, we are not doing it. Then if there is acute pelvic infection, okay, because you will lead to a spread of the infection, then cervical cancer, we again don't do a DNC. And yes, if your patient is a case of coagulopathy, because it increases the risk of bleeding. So these are the places where we would avoid a DNC, right? Chalo, let's go on to the next question. Your patient is MCDA twins. She is 28 weeks pregnant. There is a hemoglobin discordance, but the amniotic fluid volumes are not discordant, they are normal. So what are we dealing with? Are we dealing with twin-twin transfusion syndrome? No. Remember, the diagnosis of twin-twin transfusion syndrome is when one twin has polyhydramnios and the second twin simultaneously will have oligohydramnios. So if this is not present, then the answer is TAPS. Okay, so twin anemia polycythemia sequence. Okay. In selective IOGR, there would be a growth discordance of 25%, right? Vanishing twin is not specific to monochorionic twins, okay? It can happen in any twin pregnancy. What do you see here? When early pregnancy may, initially you have seen 2 gestational sacs, but when you follow up, 1 sac disappears, right? So there is a spontaneous abortion. So it's happening very early. So there is spontaneous abortion of 1 twin. Does it cause any problems to the pregnancy? No. So the rest of the pregnancy will continue as it is. Okay, please remember, when we talk about MCDA twins, they are the most common type of monozygotic twins. But if we are asking overall in general most common type of twins, then overall is DCDA. Also remember, MCDA twins are formed when the cell division happens in which time period? From 4th to 8th day, right? If it happens in the first 3 days, it is DCDA. If it happens from 8th to 12th day, it is MC and MA. And beyond 12, it is going to be conjoined twins, right? Ultrasound markers yaad hone chahiye. So please remember, lambda sign, also called as twin peak sign, is a marker of DC twins, which we see on ultrasound around 10 to 14 weeks, whereas T sign is a marker of monochorionic twins. Okay, chalo. Which of the following statements about pre-implantation genetic diagnosis is true? Then obviously the answer is going to be C. So yes, very, very important. Pre-implantation genetic diagnosis needs IVF. You cannot do it in naturally conceived pregnancies, and that is why option B is incorrect. Okay. Second, we need some tissue to do this diagnosis on. So we are either going to use the blastomeres, okay, so which we get from Day 3 embryos, which are also called as what? Cleavage stage embryos. Okay, or we can use the blastocyst ka trophoectoderm. So day 5 pe we will use the blastocyst trophoectoderm, which is actually the best method for pre-implantation genetic diagnosis. Remember, we will make the embryos. So to do PIGD, you will have to pierce the zona pellucida. अब problem क्या है? We all know zona pellucida becomes very hard after fertilization. So आपको पहले उसे soften करना पड़ेगा, and therefore these embryos are kept in calcium and magnesium free media. Okay, so calcium and magnesium free media में इसको रखते हैं, which will lead to softening of ZP, and then you will pierce it. Then it is contraindicated in monogenic. No, absolutely wrong. In fact, the most common indication, okay, to do PIGD is monogenic disorders, right? So most common indication is monogenic disorders like thalassemia, okay, like sickle cell, like cystic fibrosis. So उनमें ही सबसे ज़्यादा ये useful है. Yes, we can do it for aneuploidy. वो बात ठीक है, but we don't do it in naturally conceived pregnancies. Option A is also wrong because it is not performed after implantation. ये तो statement में ही, option में ही है. It is pre-implantation genetic diagnosis. So before you put the embryo into the uterus, you have to test them for the disease. Okay. Chalo, let's go on to the next one. According to the national guidelines, which statement about antenatal care is true? So yes, the answer is D. The first antenatal checkup should be preferably in the first 12 weeks, actually as soon as possible, but the guidelines say it should happen in the first 12 weeks. Okay. Option C is wrong because when we talk about TD vaccine, we give one dose, and this is given at the first antenatal visit, and then 4 weeks later we will give the second dose as well. Remember, one dose sirf tab dete hain if, which is the booster, if the pregnancy is within 3 years of a previously immunized pregnancy. Then yes, we will give only what? Then we will give only one booster dose. Okay. Minimum of 6 antenatal visits? No. As per the Government of India, our minimum requirement is 4. As per WHO, it is 8. Okay. Iron, folic acid, and what is the ideal number? Ideal number is somewhere between 12 to 14. Okay. FA should begin from 3rd trimester. No. Iron, folic acid supplementation begins from 2nd trimester. So beyond 12 weeks, we will start giving it to all pregnant women. Each tab has 60 milligrams of elemental iron and 0.5 milligrams of folic acid. We are going to give, yes, 1 tab per day for 180 days during pregnancy and also 180 days after delivery to maintain the stores. Remember, iron के साथ calcium भी देते हैं to all pregnant women, and the minimum gap between the two should be 2 hours. Okay. All right, let's look at the next one. So your patient is 30 weeks pregnant. She is HIV positive. We have her viral load and we have her CD4 count. What are we going to do with antiretroviral therapy? So yes, very, very important as per the NACO guidelines. So our national guidelines say we have to start triple drug therapy, okay, which is irrespective of the viral load and irrespective of POG. So we will start it whenever the patient presents to us. So can we give it in first trimester? Yes. Okay. Then we are going to conduct a vaginal delivery. Yes. So HIV by itself is not an indication for cesarean section. Okay. So our guidelines say we will do vaginal delivery irrespective of viral load. This is different from American guidelines where they say if it is less than 1000 copies, then we will do a vaginal delivery. If it is more than 1000 copies, we will do a cesarean. Here in India, as per NACO guidelines, we would do cesarean for only obstetric indications. okay, like HIV and placenta previa, then yes, we will do a cesarean. We do not delay antiretroviral therapy. I said it has to be started immediately. Also, it has to be given lifelong, right? So, lifelong antiretroviral therapy has to be given, okay. Plan elective cesarean is incorrect. As I said, the route has to be vaginal, okay. Now, please remember, when we talk about HIV, you have to avoid ARM, you have to avoid prolonged labor. So, whenever required, you will do the augmentation. You have to also avoid instrumental delivery, and you will not do any kind of internal invasive procedures, right? So, avoid invasive monitoring procedures. So, these are some of the other things that we should know. And yes, HIV has to be advised to all pregnant women at first antenatal visit. Our screening method for HIV is called as opt-out screening. Okay. Chalo. According to the national guidelines, which of the following steroid will be preferred for lung maturation? So, you have to know that the Indian guidelines are not betamethasone, they are dexamethasone, right? So, yes, the answer is 6 milligrams of dexamethasone, which is given every 12 hourly for 4 doses. Yes, betamethasone can also be given, and then the correct dose is 12 milligrams, given 2 doses 24 hours apart. But as I said, this is actually the dose for betamethasone, right? But as I said, so option A is also correct, but it is not the Indian guidelines, because betamethasone का जो salt हमें चाहिए वो expensive होता है and it is not readily available. So WHO says Dexa is equally effective and our national guidelines say dexamethasone. Now please remember, there is clear benefit of giving steroids from 24 to 34 weeks. Beyond 34, the guidelines differ. But yes, some international guidelines say that they can be given beyond 34 weeks up to 36 plus 6, so which is the ACOG guideline, while the NICE guidelines say give it up to 35 plus 6. So yes, the benefit is doubtful, but it can still be given. Clear benefit is between 24 to 34 weeks, okay. Remember, these are intramuscular injections, okay. Chalo, steroid कब नहीं देना है? So when is steroid contraindicated? So whenever you have to do an urgent delivery, you don't want to give it in a patient of impending eclampsia or eclampsia. Our goal is to deliver the patient. We will not even give it in chorioamnionitis, right? Because we want to conduct an immediate delivery. If there is fetal distress, right, we don't have time to give steroids. We have to deliver the baby, okay? So these are some important areas that you should remember. Okay, a 30-year-old primate delivers fetal head, but it retracts against the perineum. What sign are we talking about? We are talking about the turtle sign, right? Which means we are talking about shoulder dystocia. So this is when there is more than 1 minute delay in the delivery of the shoulders after the delivery of head. Then you say, yes, there is shoulder dystocia, it is an obstetric emergency, right? So what are we going to do? So the first thing we do is McRoberts maneuver. अगर McRoberts maneuver fail हो जाता है, then we will give the suprapubic pressure. Yes, so then we will give the suprapubic pressure, and then if that also fails, then the next thing is delivery of posterior arm. Delivery of posterior arm is a more easier procedure to be done with better outcomes, so it should be preferred first over the rotational maneuvers, right? So what are the rotational maneuvers? The rotational maneuvers are Wood's corkscrew, right? So Wood's corkscrew and Rubin's maneuvers are rotational maneuvers. They are done after delivery of the posterior arm. Okay, then we will talk about the next question. So I know you're not able to see me, but just give me a minute. I'm going to be here with you. So let's look at this question. So which of the following is least likely finding with the specimen shown below, right? So what are we dealing with here? So we are dealing with a grossly enlarged uterus, right? So this is a grossly enlarged uterus. But what we can also see is it looks very symmetrically enlarged. It looks like a globular uterus. And then yes, maybe some of you are able to pick up the punctate spots as well. Those are areas of hemorrhage. So this is a specimen for adenomyosis, right? Now we are asking you which is the least likely finding. We all understand progressive dysmenorrhea. We also understand heavy menstrual bleeding. But does it present with infertility? Yes, it could also present as infertility. Does it present as a big abdominal lump reaching umbilicus? No. So please remember, in adenomyosis, the uterus grows only up to 10 to 12 week size. If it is as big as reaching the umbilicus, or if it is becoming an abdominal organ, then this is likely to be a fibroid uterus, not adenomyosis, right? Now, please remember, in adenomyosis, apart from this, the uterus tends to be tender and it tends to be a soft uterus. Fibroid का uterus firm होता है, generally non-tender होता है. Investigation of choice will remain as transvaginal ultrasound. You should remember the findings that I have taught you, right? Like salt pepper myometrium, like heterogeneous myometrium, like myometrial cyst, right? Like Venetian blind appearance, okay? And very important, a poorly defined junctional zone. Okay, chalo. Your patient presents with primary amenorrhea. She has no secondary sexual characters. Height is also below the 3rd percentile. Webbed neck hai, shield chest hai. So what are we dealing with? We are definitely dealing with Turner syndrome, right? Because this is the most common type of gonadal dysgenesis, where you will come across what? Primary amenorrhea with absent secondary sexual characters, right? And I'm sure you all remember the karyotype, obviously, which is 45XO. But let's see what the question is asking. So all are true except, kya answer hai? High risk of gonadal malignancy. Although it is a gonadal dysgenesis, there is no risk of gonadal malignancy. We don't do a gonadectomy here. Yes, FSH will be high. That is why it is called as hypergonadotropic hypogonadism. There is high risk of diabetes as well as Hashimoto's. There is high risk of coarctation. Yes, even a bicuspid aortic valve, and in fact even horseshoe kidney. But as I said, there is no risk of gonadal malignancy. Remember, gonadal malignancy का risk किसमें होता है? Swires में. So Swires is a type of pure gonadal dysgenesis, right? इसमें भी there are streak gonads just like Turner's, and इसमें भी secondary sexual characters are absent. ठीक है, ये भी absent हैं. But what are the things? इसमें the karyotype is XY, the stature is normal, and you will have to do a gonadectomy. So this is how it is different from Turner's. Chalo. Your patient comes with cyclical lower abdominal pain. She has not attained menarche. Okay, secondary sexual characters are normal. There is a tender pelvic mass, a bluish bulging membrane at the introitus. So we understand we are dealing with what? Yes, imperforate hymen. The question क्या है? Question पूछ रहा है most likely immediate complication. So is it PID? No, it is the membrane is closed and there is no way the organisms can enter inside. So in fact there is no as such risk of infection. Infertility due to adhesions, unlikely. That would only happen secondary to infection or instrumentation. Yes, it can be endometriosis, but it is not a immediate complication. It is a long-term complication because of retrograde menstruation. Immediate complication can be, yes, acute urinary retention. Why? Because if the patient has a big hematocolpos, it is going to obstruct the urinary tract and cause retention. Yes. Now, please remember the management is cruciate incision and everything else is normal in imperforate hymen. So, they have a normal karyotype, normal ovary, normal hormones, normal secondary sexual characters. सब कुछ normal है other than the hymen. Okay, chalo. So, which of the following is not a component of active management of third stage of labor? Do we give oxytocin within 1 minute? Yes. You can also give it at the delivery of anterior shoulder. That is also an alternative. So, this is true. Okay. Controlled contraction? Yes. This is called as modified Brand-Andrews method. Okay, delayed cord clamping for 1 to 3 minutes. Yes, this is universal, right? So, this is what we do for everyone as long as it is a vigorous baby, which means the baby does not need resuscitation. So, we will do it for all vigorous term as well as preterm babies. Routine uterine massage? No. Okay. So, please remember this is not a recommendation by WHO. What WHO says, you should do an intermittent uterine tone assessment. Okay. Please remember, we definitely are not going to do a bimanual compression. अगर ये दोनों options में है massage and compression, क्या आंसर करोगे? Which is not a component. Then we are going to go with bimanual compression. You are not going to do bimanual compressions for every laboring woman. It is done as a part of management of PPH. Okay. Chalo, agla karte hain. Your patient presents with infertility. Small firm testes hai, gynecomastia is there, sparse facial hair are there, azoospermia, high LH and FSH, low testosterone, सब कुछ तो दे दिया. The reason is because I want you to know these features about Klinefelter's, right? So, we are dealing here with Klinefelter syndrome, which is 47XXY, which is the most common sex chromosome abnormality. Yes, obviously, because it is a problem in number, it is a type of aneuploidy, as is Turner's. Okay. What is the most likely karyotype and the most common associated finding? So, karyotype to मैंने लिख दिया. What is the finding? It is B. Definitely they have increased risk of breast cancer. Please remember, they also can have tremors, osteoporosis, cardiovascular problems. Okay, they are very common. So, these are some very, very important things. Again, autoimmune diseases like diabetes, Hashimoto's, SLE, RA, ये सब भी बहुत होता है. ठीक, so remember these features of and what kind of azoospermia is this? Yes, so these men have primary hypogonadism, right? Or we can say hypergonadotropic, जैसे Turner's था, hypogonadism. Okay, and they have non-obstructive type of azoospermia. Okay, so they have non-obstructive azoospermia. Chalo. Your patient has a history of vaginal hysterectomy 10 years ago. Now she is coming with vaginal bulge and incomplete bowel emptying. There is a vault prolapse. What is the most definitive management for her? So, when we talk about vault prolapse, right, are we going to give a pessary? No, it is not a definitive management. Yes, so please remember, pessary is only symptomatic management. Okay. Are we going to do Colpo suspension? No. So, please remember, the full name is Birch Colpo suspension, Beta ji, which is actually a surgery for SUI, stress urinary incontinence. In fact, it is the best surgery for SUI. Now we are left with two options, sacrocolpopexy and Lee-Fort. So it is again going to be sacrocolpopexy, where we use a mesh. The mesh is placed between sacral promontory and vaginal vault. Okay. So please remember, can we do Lee-Forts? Yes, but again it is not a definitive surgery, it's more of symptomatic. So this is done for women who have comorbidities. Yes, it can be done for vault prolapse, but it is not primarily the surgery for vault prolapse. It's a symptomatic thing for various types of prolapse. Okay. All right, let's go on to the next one. Which of the following events occurs by the end of first week of embryonic development? So when we talk about end of first week, which means we are somewhere around day 6 to day 7, right? So what happens at this time? It is going to be implantation. Now very, very important. When we talk about differentiation of the three germlets, this is the period of gastrulation, and this is from 3rd to 8 weeks post fertilization. Okay, you should remember the order. Also there is information of endoderm, then there is mesoderm, and then there is ectoderm. Implantation, please remember, it begins on day 4, completes by, yes, day 10, sorry, begins by day 6 to 7. Okay, day 4 क्या था वो मेरे दिमाग में चल रहा था. Day 4 is when the morula enters the uterine cavity, but day 6 है when the implantation begins. By day 8 काफी सारा implantation हो चुका होता है, but it gets completed by day 10. Remember, implantation is as a blastocyst, which by itself is formed on day 5. Okay, is that clear to everyone? Okay, let's go on to the next one. So now this woman has frothy green discharge. So we know we are talking about trichomonas. It's a key word. There is a foul odor, there is severe itching, which means we are already ruling out bacterial vaginosis. Bacterial vaginosis में तो grey off-white discharge होता है and there is no itching. On speculum, the cervix shows the following. So this is strawberry cervix, the one with punctate hemorrhages. What is the next best step in the diagnosis? So what are you going to do? You are going to do a wet mount microscopy. Wet mount microscopy is often confirmatory. You don't really need to do a NAT. Okay, the next step is not a NAT. It is usually wet mount microscopy, where you will see the motile trichomonad. Can trichomonas be picked up on pap smear? Yes, it can be picked up on pap smear as well, but pap smear is not done to pick up it. It could be an incidental finding. KOH mount. KOH mount is typically actually done for bacterial vaginosis. You all remember we call it as the whiff test. But can whiff test be positive in trichomonas? Yes. So in trichomonas also whiff test can be positive. But अगर हम पूछते हैं किसके लिए कर रहे हो तो वो bacterial vaginosis है. Okay. Now NAT no doubt is the most sensitive test. But here we are not asking about sensitivity. We are asking you what are you going to do next. We don't do NAT next. We do saline microscopy. In fact, this is the investigation of choice for vaginal discharge. What will you see if it is bacterial vaginosis? You will see clue cells. And what will you see if it is candida? You will see pseudohyphae. है ना? Candida में मिलेगा pseudohyphae. And remember, when it's trichomoniasis, some key things. The pH is going to be more than 4.5. It is a sexually transmitted disease, so you have to treat partner. And because there is a lot of inflammation, the wet mount is going to show you more WBCs. So the ratio of WBCs to epithelial cells will be more than 1. Okay? Okay, best initial treatment for mild to moderate endometriosis in a woman not seeking fertility. So, if it is mild to moderate, the first line drug should be combined oral contraceptive pills, right? Usually, yes, we can club it with NSAIDs, but when we talk about them separately, this is the drug of choice. Also, because it's specially mentioned she is not seeking fertility. Even otherwise, OCPs are the drug of choice. We want to give them in a continuous manner. Normally, we give it cyclical. Okay? GnRH agonists would be given for severe pain. They are not first line drugs. Okay? Laparoscopic treatment is done when medical management is unsatisfactory. Then yes, we will move on to the surgical management. Okay? Yes, investigation of choice is laparoscopy. And how do you confirm the diagnosis? So, for the diagnosis, when you are doing lab, you have to take up the histopath specimen. Okay? So, that is how you will confirm the diagnosis. Okay. Your patient has come with primary infertility. She undergoes evaluation and this is the finding. What is the finding here? This is a very classical image of uniconnuate uterus, right? So, we say it is banana shaped, deviated to one side, right? Abhi dekhte hain, hum puch rahe hain what is the most common associated anomaly with this. So, this is something that I talked about, right? Very common would be urinary tract anomalies. They will be seen on the same side. Which same side? Where it is absent uterine horn or where there may be a rudimentary horn. ठीक है? So, ये same side पे मिलता है and the urinary associations can be as high as 40%. What are the other associations of uniconnuate? The other associations could be unilateral dysmenorrhea. Okay, it could also be associated with ectopic ovary as well as ectopic pregnancy. Can it be associated with endometriosis? Yes, all Mullerian anomalies can be associated with endometriosis. Okay, chalo. Most common fetal complication of vacuum. So, most common will be a cephalhematoma. So, please remember facial nerve palsy is more common with forceps. Brachial injury is also more common with forceps. Shoulder dystocia can happen with vacuum, but it is not the most common. The most common is cephalhematoma. Please remember IVH, intraventricular hemorrhages, are more common with forceps as compared to vacuum. Remember, vacuum can cause sixth nerve palsy as well as injury to retina. है ना? So, injury to retina हो सकता है, sixth nerve palsy हो सकता है, scalp lacerations हो सकते हैं. With forceps, as I said, it is more of brachial plexus, facial nerve, injury to the skin of the face, even depressed fractures and intraventricular hemorrhage. Please remember, but vacuum is definitely more easy to apply, and that is why overall it is the most commonly used instrument. Remember, I've taught you, please go through the predictor series as well. The contraindications are important when you are comparing vacuum and forceps. Okay. Primigravida is in labor, vertex presentation, occipito-posterior, the head is in deflection. What is the likely engaging diameter? So, if the head is deflexed, it is occipitofrontal. Please remember, जब पूरा deflexed होता है, तो occipitofrontal है. If there is partial deflection, if they use this word, then the better answer will become suboccipitofrontal. Okay, suboccipitobrigmatic is in vertex presentation, which is well flexed head. Okay, what about mentovertical? This is in brow presentation, right, which is also the largest fetal head diameter. It measures almost 14 centimeters. So, vaginal delivery is not possible in this. Also remember, OP is generally seen in android. So when we say OP or we say right occipito-posterior, it is seen in android. But when we say persistent OP, direct OP or face to pubes, then you are going to answer it as anthropoid. ठीक है? ब्राउ किस में मिलता है? प्लैटीपेलॉइड. फेस किस में मिलता है? प्लैटीपेलॉइड. Perfect. चलो. Your patient is 28-year-old, 3 days postpartum hai. She comes with fever, lower abdominal pain, foul smelling lochia. Okay, and the uterus is subinvoluted. So yes, this is a case of purpureal sepsis, which is a general term. Now this is specially I have given because some of you had a doubt in the predictor. Now here we haven't kept endometritis as a separate option. Had it been a separate option, yes, this is classic case of endometritis. So sepsis is a general term which we use for what? Purpureal sepsis is a general term for infection of the genital tract. When will you suspect pelvic thrombophlebitis? If the fever is not responding. Right? So if the fever is not responding despite antibiotics, if you feel a cord-like structure in the pelvis, which is the ovarian vein usually. UTI mein the patient will have urinary symptoms. Yes, it is common cause of purpureal fever, but not the most common. The most common is actually endometritis. Remember, purpureal fever is more than or equal to 38 degrees on 2 occasions from day 2 to day 10. So I think I've covered this in my predictor as well. So you can go and see more details from there if you want. Okay. But this is overall important. Okay. When we talk about uterus, remember on day 2 postpartum, it will be 1 finger breadth below umbilicus, because in first 24 hours there is no involution. By day 10 to day 12, it becomes a pelvic organ again. Okay, so by 2 weeks and day 10 to 12, and by 6 weeks there will be complete involution. Okay, so remember this. Order of lochia मुझे लगता है सबको आएगा, but yes, you should know it's a very common question. So it is rubra, serosa and alba. So usually first 3 to 4 days it's rubra, from day 5 or 4 to 9 approximately it's serosa, and then beyond or equal to day 10 it is usually alba. The average duration for lochia is 4 weeks. Okay, that's average. But yes, up to 6 weeks is considered as normal. Anything beyond that, you should look out for retained products, you should look out for infection. Okay, your patient has primary infertility, distended tubes, and there is a bead on string appearance, but this is on HSG, right? So what are we dealing with? So beads on string on HSG, you are going to mark it as hydrosalpinx. It is a distended tube, okay, which is going to show you beads on string. So we are going to go with hydrosalpinx. That is the finding on HSG. Yes, and please remember, hydrosalpinx का मतलब होता है severe tubal damage. So management is IVF. But if we do IVF alone, the embryo will not survive because the fluid is embryotoxic. So before IVF, we should do a laparoscopic salpingectomy. Okay. Remember, if it is a bilateral block on HSG, the next step should be laparoscopy plus hysteroscope. Okay, no, we have not mentioned cornual. If it is just bilateral block, we will answer it as lapro plus chromoperturbation, where we use methylene blue, है ना? But अगर एग्जाम में लिखा है bilateral cornual block, then please remember you should combine laprochromo with hysteroscopy. Why? Laprochromo will be the diagnostic part and hysteroscopic cannulation would be the therapeutic part. Also for bilateral block, this is the next step, okay, laparochromohystro. But if we say best, then yes, the best for bilateral connuval blocks would be IVF, right? So we have tried to cover the things that we need to know from these questions. So hope you find it eye yielding. Revise what we have taught you in DVT and go through the predictor test as well, right? Wishing you good luck, all the best everyone, and I am sure you are going to come out with flying colors. Our blessings and wishes are with you, and we are going to definitely pray for your success. And as we say, apna time apan khud laega.
Welcome to the recording of medicine question solutions in the NEET mock test. The first question, a 60-year-old patient presents with dyspnea and the chest discomfort, and thoracocentesis is performed for the same person. On the Light's criteria, what can be used to classify the effusion as an exudative effusion? In an exudative effusion, the pleural fluid is likely to have more protein, likely to have more LDH, but likely to have less glucose and less pH. Because if there is an active infection, we are going to use up the glucose and lower the pH of the solution. So the correct answer to this question is option number A. When the pleural fluid protein to serum protein ratio is more than 5, it is specific for the diagnosis of an exudative effusion. In the stop bank questionnaire, what does the word O stand for? The O stands for observed apnea. So let us look at in the sleep apnea questionnaire, the stop stands for the symptom. S for snoring, T for tiredness, O for observed apnea, and P for the blood pressure, elevated blood pressure. Along with that, if you look at the risk factor, which is composed of BANG, that is body mass index, age of the patient, the neck circumference, and the gender of the patient. The neck circumference and the gender of the patient contribute to the risk of developing the sleep apnea syndrome. So the correct answer, O, stands for observed apnea syndrome. Like I tell in the class, that when a patient complains of snoring, you tell the relative to observe the patient during sleep. Whenever there are episodic stoppage of snoring, when the breathing stops, apnea, that is important to suspect the sleep apnea syndrome and ask for polysomnography. Question number 3. Which of the following is a distinguishing feature of the group 2 pulmonary hypertension? Group 2 hypertension are those related to left heart disease like mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. That is called as the group 2 causes of pulmonary hypertension. In the group 2 causes, the typical feature is the elevated PCWP, because the PCWP or the pulmonary capillary wedge pressure reflects the left atrial pressure, and that is why elevated. Hence it is elevated only in patient with the left heart disease, and that is why it is a typical finding in the group 2 patient of pulmonary hypertension. Question number 4. What is the first line of treatment in a hemodynamically stable patient? Hemodynamically stable indicate it is a mild case of pulmonary thromboembolism, which can be managed with anticoagulation therapy alone. Thrombolysis embolectomy are reserved for severe cases who present with shock. Question number 5. A patient with COPD comes with the following ABG finding. The pH is less than 7.40 going down, indicating it is acidosis. The patient has got a PCO2 value 55 more than 40 going in opposite direction, telling you that the primary defect is respiratory. But in the respiratory disease, bicarbonate has also increased. That means there is compensation present. So the diagnosis is best written as option number B. It is a compensated respiratory acidosis in this patient. Which ABG is most indicative of a mixed respiratory and metabolic disease? Remember the dictum, when the PaCO2 and the bicarbonate value move in different direction. When they are moving in the different direction, the defect is likely to be mixed because usually they go simultaneously. For example, we know when the patient is having metabolic acidosis, we have studied when the pH is going to go down in acidosis, what you are expecting? Drop in PaCO2 and drop in bicarbonate is expected. But in the first option, when the pH is going down, but the PaCO2 is going up and the bicarbonate is going down. So this is opposite. Here it is going up and bicarb is also going down. That indicates patient is having a mixed respiratory and metabolic defect. Question number 7. Match the urinary cast with the probable diagnosis. The presence of the hyaline cast is seen as the most benign finding. Also, it is the most common cast in the urine. The presence of muddy brown cast is specific for acute tubular necrosis. The presence of the waxy cast is seen only in advanced case of CKD, and the presence of RBC cast is specific for diagnosis of acute glomerulonephritis. So correct answer option number A. Question number 8. Which of the following genetic mutation is most commonly associated with Alport syndrome? Alport syndrome is most commonly a X-linked defect in the alpha 5 subunit of type 4 collagen. Alpha 5 subunit of the type 4 collagen have got the defect in Alport's syndrome. The genetic defect is the collagen 4 alpha 5. So type 4 alpha 5 gene defect is seen in majority patient of Alport syndrome. Question number 9. What is the recommended screening test for the early detection of diabetic nephropathy? In all the high risk patient, we must screen for microalbuminuria using albumin to creatinine ratio, because microalbuminuria is the earliest abnormal finding in a patient with diabetic nephropathy, and it can be reversed by early use of ACE inhibitor or ARB therapy can be used to reverse this pathological finding. Question number 10. When a 60-year-old obese man is got a history of hypertension, patient is also diabetic with hypertriglyceridemia. So patient has got multiple metabolic risk factor is present. But along with that, patient is not as alcoholic. Patient though has elevated transaminitis. So there is inflammation in the liver is present, but hepatitis panel, autoimmune panel is negative, ceruloplasmin, ferritin level is normal, and there is generalized hyperechogenicity, suggesting active disease is present in the liver. This is most likely a case of NASH. Non-alcoholic steatohepatitis is the likely correct answer. Question number 11. Which anti-diabetic drug is useful in hepatic encephalopathy? We can give acarbose. In hepatic encephalopathy, we give lactulose, bowel wash orally. Acarbose also by inhibiting glucose reabsorption. By inhibiting the glucose reabsorption, it increases the glucose present in the gut, which promotes the growth of the lactate, growth of the Saccharomyces, that is saccharolytic organism, which are non-pathogenic. These will inhibit the proteolytic organisms, and by that hence reduce the ammonia production. Which can be useful in a patient with hepatic encephalopathy. Question number 12. All are true regarding primary biliary cholangitis except for, we all know primary cholangitis is an autoimmune disease. So it is likely to be more common in the female. There is obstruction, there is cholestasis, and that is why there is going to be pruritus can be present. Elevation of the alkaline phosphatase is one of the key diagnostic criteria, except for it does increase the risk of hepatocellular cancer. There is a risk of hepatocellular cancer, especially depending on how much is the elevation of ALP level. More severe the obstruction, inflammation, more risk of cancer is present in the future. Question number 13. When a young woman presents with secondary amenorrhea and galactorrhea, both are representing increased prolactin state. There was also noticing of a bitemporal hemianopia. Visual field defect was there. MRI confirms the tumor is there more than 1 centimeter, means patient is having a macroadenoma of the pituitary gland. But when the patient has got elevated prolactin state, whether it is micro or macro, the first line treatment will always remain dopamine agonist like bromocriptine. The first line treatment will always remain dopamine agonist like bromocriptine, irrespective of the size of the tumor. Only if it is unresponsive to dopamine therapy, we can consider the surgical option to prevent progression of the visual field defect also. That is why correct answer option number C. 14. All are seen in gigantism patient except for gigantism is a elevated growth hormone excess state is there, which can cause visceromegaly. Example, it can cause cardiomegaly. It can cause hepatomegaly. Organomegaly can be there. Large foot, acromegaly also can be there. Cardiovascular damage because of cardiac muscle involvement, cardiomyopathy can occur, except for mental retardation. There is no defect in the cognitive function, as far as acromegaly is concerned. Question 15. Pulsus paradoxus, that means drop in the systolic blood pressure by more than 10 millimeter on inspiration is seen in all of the following except for. So pulsus paradoxus can be seen in the severe acute asthma due to the lung hyperinflation. It can be seen in a patient with cardiac tamponade, also seen in a patient with constrictive pericarditis, where there is reduced compliance of the ventricular muscle, but it has no relation to AV dissociation state. All except AV dissociation state. The Canon A wave on the JVP is a characteristic feature which indicates the right atrium and right ventricle are contracting simultaneously. Hence there is a closed tricuspid valve causing Canon A wave. It is a character of AV dissociation state. The conditions associated are third degree AV block and patient with ventricular tachycardia can develop Canon A wave on the JVP. Correct answer option number C. Loud S1 is seen in all of the following except for. Loud S1 is seen in anemia because it is hyperdynamic state. In the mitral stenosis, where the mitral valve leaflet are stretched to the limit to allow the maximum blood to pass across the stenosed valve. Can occur in tricuspid stenosis also, but exception is the mitral regurgitation, where you will get soft or muffled S1. Exception to the rule. Question number 18. Valsalva maneuver per se is going to reduce the preload, and what you are expecting, and you can expect decrease in the intensity of the murmur in all cases, in all condition except two of them. You can expect decrease in the intensity of the murmur after Valsalva. Exceptions are only two: mitral valve prolapse and HOCM. Correct answer option number C. I keep repeating. These are exception to the rule. Whenever any maneuver decreases preload, decreases afterload, flow across the lesion is also reduced. So intensity should also reduce. Exception to the rule are MVP and HOCM. That is why commonly asked in MCQ. Question 19. When a 79-year-old male presents to the doctor after wife noticed that he had slowed down and posture has changed, what would support the diagnosis of Parkinson's disease? Parkinson's disease comes with the extrapyramidal symptom characteristic triad of tremor, bradykinesia, and rigidity, not spasticity. That is why not the correct answer. Vertical supranuclear palsy can be seen in progressive supranuclear palsy. The presence of the postural tremor is also unrelated to Parkinson. But the shuffling gait, we also call it as the festinant gait, is very typical of the Parkinson's disease. Question 20. Which of the following is most useful in the diagnosis of Parkinsonism? Answer: clinical examination. Many neurology conditions are still in the domain of clinical acumen because there is no test that can replace the clinical acumen. Though in modern dopamine PET scan, dopamine PET CT is available, though it is expensive and may not be conclusive. So clinical examination remains even today most useful in diagnosis of Parkinsonism. But which patient of Parkinsonism is best candidate for DBS or deep brain stimulation? We say that it is the tremor dominant Parkinson or the patient who has developed drug induced dyskinesia, either the tremor dominant or person developing drug induced dyskinesia are best candidate. That is why among the options given, best option is option number C. When there is a tremor which is unresponsive or drug induced, best treatment is DBS, deep brain stimulation. When a 58-year-old woman develops acute onset of weakness on right side of her arm and left arm with slurring of speech, she is assessed for thrombolysis. In thrombolytic protocol, which is single most important action, do a CT brain stat in order to exclude the hemorrhage. Do immediate CT brain to exclude the hemorrhage. That will give you correct answer. Question 23. When a 75-year-old male presents with an acute stroke, having mild right arm and face weakness, patient has got spontaneous speech, means the Broca's motor area is all right. Patient can understand and follow command. That means comprehension, sensory area also intact. The only defect is repetition is severely impaired, which is typical of the conduction aphasia. Arcuate fasciculus fiber is affected, where repetition is affected. That is conduction aphasia. When a 21-year-old man has got a subarachnoid hemorrhage, patient, the CT has confirmed that there is a middle cerebral artery aneurysm, but the patient suddenly deteriorates with fixed pupil. Then what is the likely cause? Re-rupture. Sudden deterioration, re-rupture or the re-bleed from the aneurysm is most likely cause. Vasospasm comes after 7 days, typically subacute or a delayed complication. Hydrocephalus, late complication. But sudden worsening is typical of the re-rupture of the aneurysm. A 50-year-old female recently diagnosed as a case of rheumatoid arthritis has been referred to you. Which joint is usually spared at the onset of RA? Answer are the DIP joint. DIP joint involvement is late and rare in a patient with rheumatoid arthritis. Rather, we have studied early DIP involvement favors the diagnosis of the psoriatic arthropathy. It favors the diagnosis of a psoriatic arthritis. That is why exception to the. So I hope you are getting the questions correct. Please remember concepts are very important on the day of exam because you have studied a lot of content. But it is now time for you to remain calm, read the question carefully, apply the knowledge that you have and get your best desired result. All the very best.
Hello guys, let us look at the questions from pathology in this exam. I am Dr. Sanjeev Chitragar, your pathology teacher. Okay, let us start with the first question. What is this? Last line if you want. Okay, this only short question. I can start with the first line also. Mother of a 2-month-old boy complains that the boy is having a salty sweat. Okay, tell me now, what are you suspecting? Salty sweat in the baby. You suspect what condition? Okay, and you start suspecting a genetic disease. Okay, that's what they have given. Which of the following is not associated? So that means the key word is salty sweat. Salty sweat in a baby. I start suspecting what condition? Cystic fibrosis, isn't it? One of the most commonly is what? Cystic fibrosis. I am suspecting cystic fibrosis in this boy. So now what is the question? Which of the following is not associated? That is the question asked to me. Which is not associated with cystic fibrosis? Cirrhosis. In fact, yes, cirrhosis can be associated with cystic fibrosis because there can be obstruction to your bile duct and the pancreatic duct that can lead to cirrhosis, secondary cirrhosis. Malabsorption syndrome. Very common in cystic fibrosis because there is an obstruction to pancreatic duct. There will be no secretion. Not only that, there is also auto destruction of pancreas happening. Type 2 diabetes mellitus is not associated, and the correct answer, it will be type 1 diabetes is associated, not type 2. The pathogenesis of diabetes happening in cystic fibrosis, there will be obstruction to pancreatic duct. That is why the pancreatic enzymes stay inside the pancreas only, and they get activated. Once they get activated, they will destroy the both exocrine and endocrine. Exocrine pancreas destruction will lead to malabsorption, we understood, and endocrine destruction will lead to type 1 diabetes. Type 2 is due to insulin resistance. Recurrent respiratory infection, yes, because there will be obstruction, there will be recurrent pneumonias, and bronchiectasis eventually will be the complication happening in cystic fibrosis, right? Yes, so this is your next question. Number 2, which of the following is associated with, so it's a one-liner question, which of the following is associated with human T lymphotropic virus 2, HTLV2? So this is HTLV2, primary effusion lymphomas. No, primary effusion lymphomas are caused by, primary effusion lymphomas are caused by predominantly HHV8. That is the first one, even EBV also. Primary CNS lymphomas are also caused by either HHV8 or they can be Epstein-Barr virus. Adult T-cell leukemia lymphoma, this will be caused by HTLV1. So this is also not the answer. T-cell variant of hairy cell leukemia, that is a correct answer. Remember, there are hairy cell leukemia mostly are B-cell neoplasms. They are caused by EBV. But whereas a T-cell variant of hairy cell leukemia is caused by HTLV2. Okay, primary CNS lymphomas are predominantly caused by EBV. You can write it EBV first, then maybe HHV also you can write. Okay, yes. So this is what is your, HHV also causes what? Kaposi sarcoma. Okay, this is one of the question, basic question. Question number 3, let us look at this next question now. Okay, lengthy question. What is the, which of the following is likely deficiency? Which of the following deficiency is most likely cause of such a blood picture? So they are asking what is a blood picture. Okay, iron and folic acid, iron and B12, iron and B6, B12 and folate. Okay, so they have given various combinations here, isn't it? Let me start a question now. Question: a 10-year boy is suspected to is having diarrhea, for last 2 years. 10-year boy is having a chronic diarrhea. Biopsy is suspicious of celiac disease. So celiac is causing diarrhea. We understood celiac. There will be villus atrophy, etc. happening in the duodenum, jejunum. Peripheral blood smear examination shows a dimorphic anemia. What is dimorphic anemia? Dimorphic, two morphologies are seen, isn't it? So which are the two morphologies? Dimorphic means you are seeing both micro and macrocytic, both are seen. Microcytic and also what? Macrocytic are seen. That means there is a deficiency of both of them. So both micro and macrocytic cannot be option D. B12 folate will only cause, both of them if they are deficient, only macrocytic. Iron and B6 is pyridoxine. Pyridoxine will also cause sideroblastic anemia, which is a microcytic. So both this will be causing microcytic. So is it iron folic acid? Is it iron B12? Which one is it? Celiac disease patient, I will write iron and folic acid because folic acid is absorbed from jejunum. In celiac, the disease is happening in the upper intestine, which includes your duodenum and jejunum. B12 malabsorption doesn't happen in celiac because B12 gets absorbed from terminal ileum. There is celiac is affecting the proximal intestine, not the distal intestine. Right? So answer to this question A, iron and folate deficiency. Next, question number 4. Okay, let me look, lengthy one, last line. Which of the following is most likely diagnosis? So I'm happy when examiner asks only one diagnosis. Option are lymphomas: small lymphocytic lymphoma, mantle cell lymphoma, follicular lymphoma, and a marginal zone lymphoma, isn't it? Okay, let me see the question now. Patient presents with easy fatigue for the last 1 year. So it is a gradual onset disease. General physical examination is unremarkable except solitary cervical lymph node. There is only one cervical lymph node. Biopsy from the lymph node shows effaced architecture by monomorphic cells. So if it is this is there, definitely this is suggestive of lymphoma. So effacement of architecture is lymphoma and monomorphic cells, lymphoma, which were positive for. More important now, markers have come. Let us look at markers. What marker should I pick? I should pick whatever I want. I will first pick CD20, given as positive. It is a B cell neoplasm, correct? So after that 20 to 79, I am not interested. I am interested in 5. 5 has been given one negative. 5 is a negative. That means it is not pre-germinal, isn't it? So this is not pre-GC. So that means it is not a SLL, it is not a mantle cell lymphoma, because both of them are pre-germinal, isn't it? Next, it is 10 negative and 23 negative. If it is 10 negative, it is not what? So 10 negative, it is not germinal, not precursor also. So it is not germinal, not precursor as well. Then what are you thinking here? So it is neither germinal nor precursor. So now my diagnosis, this is post-germinal center. And in the given option, marginal zone lymphoma is a post-germinal center. That is why the answer is post-germinal. Next question 5. Let us look at this. Which of the following is most appropriate finding of the histological description? So what is the most appropriate finding of the histological description? There is a desmoplasia, hamartoma, choristoma, anaplasia. 10-year-old boy presents with bleeding per rectum. Colonoscopy shows a polyp. Biopsy from the same shows mature glands. So there are mature glands, there are smooth muscle and connective tissue all admixed together. So they are haphazardly arranged normal things, and that is why these are hamartoma, isn't it? Desmoplasia is fibrosis, choristoma is ectopic, anaplasia is pleomorphic cells, poorly differentiated cells, right? Yes. Question number 6. Which of the following is the function of inflammasome? Oxidative burst, RIP activation, collagenase activation, interleukin-1 activation. Answer, inflammasome is IL-1 activation. Inflammasome in fact activates caspase 1. Caspase 1 eventually leads to IL-1 activation. So best answer would have been caspase 1 activation. That is not given. Answer will be IL-1 activation. RIP activation is done by, this will be done by necrosome, isn't it? So this is done by necrosome. So necrosome will be seen in necroptosis, right? Yes, best answer would have been caspase 1. That is not there, interleukin 1, because caspase 1 eventually activates interleukin 1. Next, question number 7. Gross examination of spleen in a patient who died with complication of rheumatoid arthritis is as follows. So what are you seeing? And this is a cross examination. Which of the following is most likely diagnosis? They have given option lymphoma, amyloidosis, miliary tuberculosis, and a metastatic carcinoma. So they have given us a history of rheumatoid arthritis. So I have to first look which disease is associated with RA. Rheumatoid arthritis, very commonly associated disease is amyloidosis, one of them. Others can also be associated, but amyloidosis frequently, because rheumatoid is the most common cause of amyloidosis. Can it be amyloid? Yes. What am I seeing here? This is your classical sago spleen that you are seeing. What is a sago spleen? What pulp of the spleen is involved here? Sago spleen that you are seeing, gross examination. Here the white pulp of the spleen is involved, right? Yes. Next, let us look at this question, guys. Yeah, tell me please, guys, look at this question. What is it? Okay, what is the last line again? Which of the following is the best way to reduce fever in subsequent transfusion? So they have given which of the following is the best way to reduce fever in subsequent transfusion. prophylactic broad spectrum antibiotic, prophylactic aspirin, saline washing of RBCs, irradiated RBCs. A patient with thalassemia who has received multiple blood transfusion till date is found to have increased incidence of fever in the last few transfusion. So fever is happening. What is the mechanism of fever? If you remember, then answer will be easy. Fever is febrile non-hemolytic transfusion reaction. This is primarily because of anti-HLA antibodies from the patient. They will kill the WBCs from the donor, and once they kill the WBC from the donor, this will lead to release of IL-1 TNF alpha, and this IL-1 TNF alpha will be causing fever. We all know this. This is febrile non-hemolytic transfusion reaction type 2 hypersensitivity. It is a category 2 reaction. How to prevent? Simple. Make sure the donor WBCs are not there. Prevention is done best by irradiated RBC. Antibiotics not required because it is not an infectious cause. Prophylactic aspirin, theoretically you can prevent, but I don't want to give aspirin prophylactically before blood transfusion, because what if DIC happens or any other complication will happen. So aspirin should not be used in blood transfusions, right? Yes. Next, question number 9. Let us look at this question now. Okay, what is this question? Last line. Okay, you start suspecting manifestations are secondary to a tumor. Which of the following tumor is it likely? So manifestations are secondary to some tumor: glioblastoma, lung carcinoma, medullary thyroid carcinoma, and a renal cell carcinoma. So some manifestations examiner has given, and we have to suspect which malignancy. Patient presents with weight loss. So weight loss is there, of course, that is why malignancy. Okay, anyway, so weight loss. Now he has presented to you having mental confusion for the last few days. Okay, so there is CNS manifestation, mental confusion, episodes of seizure and delirium also. Blood culture shows a serum sodium 110, calcium 9. Yes, you start suspecting. Serum sodium 110 is low. So serum sodium is low with mental confusion, delirium, diarrhea, vomiting also they have not given to us, but anyway. So I am suspecting SIADH. That will be a lung carcinoma. So I am suspecting a lung carcinoma. Paraneoplastic manifestation, lung carcinoma. Hypercalcemia also can occur in squamous cell carcinoma. SIDH will be mostly in small cell carcinoma of lung. Right? Paraneoplastic of renal cell carcinoma will be polycythemia. Right? Okay. Next, question number 10. Okay, let me see. Which of the following is likely diagnosis? They are asking you diagnosis. They have given an image. Option given are Ewing sarcoma, metastatic retinoblastoma, Burkitt lymphoma, and rhabdomyosarcoma. 15-year-old boy presents with a bony tumor. So the moment they give bony tumor, unlikely to be, okay, metastatic retinoblastoma is okay for me. Burkitt lymphoma, unlikely to be a bony tumor. Anyway, in a flat bone, histological examination shows Omer-Wright rosettes. Omer-Wright rosettes, where do you see? Amongst them, Omer-Wright. In retinoblastoma, you will not see Omer-Wright, you will see Flexner-Wintersteiner. Omer-Wright rosettes are seen in medulloblastoma, neuroblastomas, and Ewing sarcoma. So in the given option, only one Ewing sarcoma is there. Rhabdomyosarcoma will not show Omer-Wright rosette, it can show tadpole cells, it can show alveolar pattern. Burkitt lymphoma will show starry sky pattern, right? So in this, only one Ewing sarcoma. The tumor cells were positive for CD99. That is also enough to make a diagnosis of Ewing sarcoma. So look at this. This is a classical Omer-Wright rosette where the tumors are arranged in a circular fashion and there is some cytoplasmic processes in the center. So Omer-Wright rosettes are seen in neuroblastoma, Ewing sarcoma, PNET, and medulloblastomas of brain. Okay, and Omer-Wright rosette is a pseudo rosette. Question number 11. C3 nephritic factor, one-liner question. C3 nephritic factor is, so what is C3NEF? So C3 nephritic factor, NEF, and the disease is called C3NEF disease. Antibody to C3 convertase, antibody to complement 3, antibody to the basement membrane of the glomeruli, antibody to phospholipase A2 receptor. Answer is option A. Misprinted as B here. It is antibody to C3 convertase. So in C3 nephritic factor, it is an antibody to C3 convertase. It goes and binds to C3 convertase and it prevents the degradation of the C3 convertase. That is why there is a persistent activation of complement which is leading to the disease. That will lead to dense deposit disease, or also called as type 2 MPGN. Type 2 MPGN, right? Next, question number 12. Which of the following is most likely cause vinyl chloride, arsenic, aflatoxin, cadmium? Okay, so this is about the chemical carcinogenesis. A 55-year farmer presents with weight loss, jaundice. Imaging shows a tumor in the liver. So if imaging is showing tumor in the liver, his work description was harvesting the food grain, storage, transportation and sale of the same. Farmer's job is that only, by the way. And yes, of course, now you start suspecting a carcinogen exposure. What carcinogen exposure you are suspecting? Answer, aflatoxin. It is from a fungal toxin which will catch on the grains, molds, right? Yes, aflatoxin. Vinyl chloride will cause hepatic angiosarcoma. It will be seen in refrigerant industry and a pipe industry. Arsenic will be in alloy semiconductor industries, can be causing many skin, lung cancer. Cadmium can be causing lung cancer, right? Yes. Next, question number 13. Yes, so let me see the question now. What is the question? Last line. Which of the following is most likely diagnosis? So they are asking you diagnosis. They have given a gross image: brown atrophy, dilated cardiomyopathy, hypertrophy and a ventricular aneurysm. 4 options are given. Okay, heart. Okay, and these are cross section. I can see this. Okay, 55-year male, known case of RHD. So it's a rheumatic heart disease, has untreated aortic regurgitation for the past 5 years, dies. The gross examination of his heart, that is the right side image, and comparable is the left side image. So yes, so the right side, this is your right side image, this is your patient's heart. So this is your patient heart, the left side is the normal heart, right? In between whatever is there, we don't know. So this is the normal, comparable is on the normal, and the extreme right is the patient's heart. And what are you seeing here? And weight of the patient's heart is 600 grams. Weight is increased. Weight is increased here. Why weight is increased? Normal heart weighs around 350 to 400 grams, right? So now look what is happening here. I'm able to see there is, yes, there is dilated. Okay, compare with the normal, there is increase in ventricular cavity. Ventricular cavity is dilated and the ventricle wall is in fact thinned. So this is normal ventricle, assuming. So there will be thinning of the ventricle happening here. So this is your, and aortic regurgitation, I can suspect this is your eccentric, yes, hypertrophy. So yeah, there is no eccentric, only hypertrophy is given. That is the correct answer. It is not brown atrophy. It is not dilated cardiomyopathy. Dilated cardiomyopathy doesn't happen in aortic regurgitation. First thing, it will happen in hemochromatosis. It will happen due to genetic causes. It will happen due to alcohol, etc. Not due to aortic regurgitation, not even due to RHD also. And dilated cardiomyopathy, the weight of the heart will be reduced, not increased there, because there will be death of the muscle. And ventricular aneurysm, no, this is not an aneurysm. Okay, question number 14. A 5-year child presents with abdominal mass. Resection of the mass is as shown below. What is the likely diagnosis? So abdominal mass in a child, what can you think of? So abdominal mass in a child, you can think of, and it's a solid organ tumor, I can suspect. So I can suspect either a neuroblastoma or even one Wilms tumor, right? 2 important tumors I'll be suspecting, 2 common ones, neuroblastoma and a Wilms tumor. And this is, and both of them will be presenting as abdominal or retroperitoneal masses. Wilms tumor will be from kidney and neuroblastoma will be from suprarenal. So yes, given options are Wilms tumor, rhabdomyosarcoma, undescended testis and neuroblastoma. I can straight away rule out unlikely to be these. Okay, rhabdomyosarcoma can occur in 5 years but not in abdomen. Rhabdomyosarcoma occurs commonly in head and neck region, isn't it? Undescended testis not in the, okay, it can have abdomen also unless there is a tumor. So it will not present as a mass, by the way. Okay, so what you are seeing, this is a fleshy mass that you are seeing. Fleshy mass that you are seeing. And this is very characteristic of fish flesh appearance, we call it. Fish flesh appearance, very characteristic in Wilms tumor. Okay, this is a kidney also, you can appreciate. This is the hilum of the kidney and this is the ureter that is there. They have done a nephrectomy here, isn't it? So Wilms tumor, that is a correct answer. Next, question number 15, the last one. Let us look at this. So yes, what is this now? Likely diagnosis they are asking: papillary carcinoma, follicular carcinoma, anaplastic carcinoma, medullary carcinoma. Histological examination of thyroid mass. Nothing else has been given. So what you are seeing blue cells, yes, round to polygonal cells, round to polygonal cells with nuclei, and more important, this pink material, this is your amyloid. So if you are seeing amyloid, what is your diagnosis? Medullary thyroid carcinoma. Option D, medullary thyroid carcinoma. So these were questions from pathology in this paper. Questions were doable. I would say if you were attentive in the class, if you are attentive with your notes, you should be able to get 15 on 15 in this. Maximum you can, one I can give you a benefit of doubt, but otherwise you should be able to solve all the questions. And these questions are at par with your NEET PG. Okay, the current pattern of the NEET PG that is there. Best wishes, guys.
Hi doctors, in this video we are going to discuss NEET PG mock test paper pharmacology. To start, I think these questions are all very easy. We start. The first question: which of the following is the true statement? Please go through one by one. Drug with a large volume of distribution can be removed by dialysis. False statement. Why false? When I say drug with a large VD, that means the drugs are extensively distributed into the tissues. They are not confirmed into the plasma. Okay, so large VD means extensive tissue distribution, intracellular distribution, and they cannot be removed by dialysis. Only when the drug is in the plasma, we can plan for hemodialysis. If the VD is large, most of drug remains in the plasma. False statement. If VD is large, most of drugs are seen in cellular compartment, tissue compartment. Okay. A highly ionized drug has low VD. True statement. So find out the true statement. Answer is option C. Why true? A highly ionized drugs are less lipid soluble and they cannot cross a cell membrane easily, and they will be distributed only in the plasma compartment. So when I say low VD, that drugs are mainly seen in the plasma compartment. This type of drugs can be removed by hemodialysis. So hemodialysis is applicable mainly for drug with low VD. Digoxin has a low VD. False statement. Digoxin having large volume of distribution. Digoxin, a cardiac drug, useful for treatment of congestive heart failure. It is one of the example for drug having large VD. So answer for the first question, option number C. Now we move on to second question. A patient diagnosed with pheochromocytoma and is given a medication to manage hypertension and symptom related to excessive catecholamine, which drug working by inhibiting the rate limiting step in the synthesis of norepinephrine. See, you know the rate limiting step in the synthesis of norepinephrine is tyrosine hydroxylase enzyme. So name the drug inhibiting tyrosine hydroxylase. Answer tyrosine. So tyrosine inhibiting tyrosine hydroxylase, which is the rate limiting step in the synthesis of norepinephrine. Okay. Look at the other option, reserpine. What is reserpine? Reserpine is a V match, that's vesicular monoamine transporter inhibitor, thereby inhibiting transport of dopamine into vesicle. The dopamine enter into vesicle. The vesicular uptake of dopamine blocked by V match blocker reserpine. Okay. What is clonidine? Clonidine, a alpha 2 agonist. Alpha 2 receptor seen presynaptically. Alpha 2 agonist going to inhibit release of norepinephrine, inhibiting release of norepinephrine. But here the question, name the drug inhibiting rate limiting enzyme. Okay. Phentolamine. What is this? It is the non-selective reversible alpha blocker inhibiting alpha 1 and alpha 2 receptor. It's a non-selective reversible alpha blocker. Okay, so a drug inhibiting rate limiting step in the synthesis of norepinephrine is metyrosine inhibiting tyrosine hydroxylase. Now, I just want to tell extra point after. For treating the hypertension and symptoms of pheochromocytoma, what are the commonly used drug in practice? Look at pheochromocytoma, a tumor of adrenal medulla. This tumor releasing large amount of catecholamine like adrenaline. This adrenaline acting on all the sympathetic receptors, namely alpha and beta, resulting in hypertension. Now question starts. Patient having pheochromocytoma presenting with the hypertension. Routinely for treating hypertension in this case, the most commonly used antihypertensive will be phenoxybenzamine. It is the non-selective, irreversible alpha blocker. It is the definitive antihypertensive for treatment of hypertension due to pheochromocytoma. But one doubt, since it's a tumor, the tumor can be removed surgically. So, before surgery, to control the BP, the best antihypertensive phenoxybenzamine. Suppose if you're planning for surgery, yes, you can do surgery, but problem while operation during surgery, when you touch the tumor will release massive amount of catecholamine that may cause sudden intraoperative hypertensive crisis. So, question, to control the intraoperative hypertensive crisis, I can go for some intravenous antihypertensive like IV phentolamine or IV sodium nitroprusside. So, during operation, during pheochromocytoma surgery, to control the intraoperative hypertensive crisis, I go for phentolamine. It's a non-selective reversible alpha blocker. It is short-acting drug useful only for emergency. IV sodium nitroprusside, a vasodilator, a fast-acting and short-acting. Short-acting drugs are useful only for emergency. So, they are useful for hypertensive emergency during a pheochromocytoma surgery. The last one point, doctor, can you please answer? For treating hypertension due to this tumor, can we use propranolol as a first-line antihypertensive? Answer no. Propranolol should not used as a first-line drug for treatment of hypertension due to pheochromocytoma because propranolol a non-selective beta blocker. So non-selective beta blocker, that means blocking beta 1 and 2. Now listen, when you go propanol as a first line, they are going to block beta 1 and beta 2. When you block the beta receptor, all the released adrenaline acting only on alpha, causing vasoconstriction and causes further hypertension. So, propranolol should not used as a first line drug for treatment of hypertension due to pheochromocytoma. Anyway, we did drug therapy useful for treatment of hypertension due to pheochromocytoma. Okay. Question number 3. A 65-year-old patient with neurogenic orthostatic hypotension experiencing significant symptoms despite lifestyle modification. Which medication is often used orally as a first line treatment for improving BP in this patient? See, patient having neurogenic orthostatic hypotension. So, for treating the hypotension, what the best oral drug first line choice? Look at the answer. Options are midodrine. Yes, that's the answer. Midodrine, a selective alpha 1 agonist. Alpha 1 agonist going to cause vasoconstriction, thereby increasing the blood pressure. It's a wonderful drug to improve BP, that too orally given drug. So, FDA approved oral drug for treatment of neurogenic orthostatic hypotension, midodrine, a alpha 1 agonist. Look at the other option, propranolol. It's a non-selective beta blocker. It's going to cause hypotension. It is not useful for treatment of hypotension. It is useful for treating hypertension, causes adverse effect of hypotension. Next, dobutamine. Actually, dobutamine is selective beta 1 agonist. It will improve the cardiac output, useful for treatment of acute heart failure. But given IV, look here, dobutamine can increase the blood pressure, but it cannot be a good choice for treatment of neurogenic orthostatic hypotension. Here, I need chronic therapy. For chronic therapy, IV drugs are not suitable. Dobutamine, a short-acting drug given only intravenously, only for treatment of hypotension, not for neurogenic. Sorry, useful only for cardiac failure, not for neurogenic orthostatic hypotension. That too, I'm asking oral drug. It is IV drug. Next, clonidine. Clonidine, a alpha 2 agonist, going to decreases release of norepinephrine, thereby controlling BP. It's an anti-hypertensive drug, centrally acting anti-hypertensive. It is not useful for neurogenic orthostatic hypotension. So, answer for the question is option number A. But one super important message. See, for treatment of, look at picture, for treatment of neurogenic orthostatic hypotension, FDA approved drugs are number one, droxidopa. It's a pro-drug of norepinephrine. One more drug, midodrine, a selective alpha 1 agonist. Remember, the two important FDA approved drug for treatment of neurogenic orthostatic hypotension are droxidopa and midodrine. Okay. Now, question number 4. Which anti-angel drug is associated with the increasing risk of bradycardia and visual disturbance? Look at the option. Ivabradine, Nicurandil, Radalinsin, Amlodipine. The right answer, go for option A, Ivabradine. See, Ivabradine, a funny current sodium channel blocker useful for treatment of angina as well as got approval for treatment of congestive heart failure. It is causing bradycardia. Bradycardia. That's the name ivabradine, causing bradycardia, also causing visual problem in the form of luminous effect, transiently enhanced lightness, increased lightness, called luminous. I am going to show, wait for some time. Look at the other option, Nicurandil. Nicurandil, a potassium opener, a vasodilator useful for treating angina, but causes adverse effect of only hypotension, sometimes causing headache, and rarely causing mouth ulcer, aphthous ulcer. Ranelazine, special drug, It's a late sodium channel blocker useful for treatment angina but causing adverse effect of causing QT prolongation. And amlodipine, a CCB useful for hypertension, angina. The point is it causes adverse effect of hypotension and very important causes ankle edema, sometimes causing constipation. That's what important adverse effects of amlodipine. Now look at Ivermectin is the answer for the question. And remember, ivermectin, a drug useful for treatment of angina. What is the mechanism action? I'm repeating, it's a funny current sodium blocker. Actually, the funny current sodium channel supplies SA node. You know, SA node is the pacemaker of the heart. The SA node undergo excitation because the SA node supplied by funny current sodium channel. By ivermectin blocking the funny current sodium channel, thereby reduces SA node automaticity, reduces excitation of SA node, thereby decreasing heart rate. So the main action of ivermectin reduces heart rate. Remember, it just reducing only heart rate. They don't have any effect on force of contraction, just reducing only heart rate. Okay. What use? It useful for treatment of angina and heart failure. And our MC question is causing adverse effect of bradycardia and luminous. Luminous means brightness, enhanced light. We call phosphine. It's also called phosphanes. So luminous. Because they're going to inhibit the sodium channel in the retina, thereby altering the perception of light. They feel like suddenly there's an enhanced lightness. They're called phosphine or luminous effect. Okay. Now question number 5. Very interesting question. Look here. Matching type of question after I given anti-epileptic drug and mechanism action. So I given drug name and mechanism action is a matching type of question. Can you please match? Point 1. Levetiracetam. Remember, levetiracetam, a anti-epileptic, it's a ligand for SV2A. SV2A mean synaptic vesicle. For example, imagine a neuron. It's a receptor. This is called, the gap is called synapse. Now, vesicle means a pocket-like structure. Now, in the vesicle, we have GABA and glutamates. So, levetiracetam acting on vesicle and modify synaptic release of GABA and glutamates. You call synaptic SV. S means synapse, V mean vesicle. So acting on vesicle modify synaptic release of GABA and glutamate. Then ethosuximide, a T type of C-sweep. Ethosuximide T type of C-sweep and T type of calcium channel is the problem in case of absensation. So ethosuximide, a wonderful drug for treatment of absensation. Coming to option number C, phenytoin. Phenytoin is sodium blocker and valproate has multiple mechanism action. It has sodium blocking property as well as GABA agonism. How they have GABA agonism? Actually, valproate going to promote the synthesis of GABA, promoting synthesis of GABA by activating glutamic acid decarboxylase. They promoting synthesis and also they inhibiting GABA transaminase enzyme, thereby preventing the metabolism of GABA. Like your vigabatrin, valproate also has the property of inhibiting GABA transaminase, thereby increasing GABA level in the brain. So it has multiple action. Sodium blocking, GABA agonism, also having anti-glutamate property. Anyway, the answer for question option number A. Okay. Now, question number 6. A 60-year-old patient with the type 2 diabetes, history of bladder cancer, concern about their medication. Which of the following drug would be least appropriate for him? See, patient is the type 2 diabetes patient, but he has history of urinary bladder cancer. So, in this patient, which anti-diabetic drug should be avoided? Answer: pioglitazone. Remember, pioglitazone, a PPAR, peroxisome proliferated activated receptor gamma. So PP, a gamma agonist, useful for diabetes, but it may cause rarely causing adverse effect of urinary bladder cancer. So pioglitazone are not good in this patient because the drug itself causing risk of cancer. Look at the other option, metformin, a wonderful first-line drug for type 2 diabetes. It causes most common adverse effect GI toxicity like indigestion, diarrhea, sometimes altered bowel habit, and also causing B12 deficiency, megaloblastic anemia. Rarely risk of lactic acidosis, especially when they give metformin in the presence of kidney failure or liver failure or in a cardiorespiratory insufficiency cases or in chronic alcoholism, risk of lactic acidosis. Sitagliptin. Gliptin mean DPP4, dipeptidyl peptidase 4 enzyme blocker. They causes mainly adverse effect of upper respiratory tract infection like sinusitis, laryngitis. Then D option, empagliflozin. The gliflozins are sodium glucose transporter 2 blocker, AGLT2 blocker, and they are causing adverse effect of mainly urinary tract infection, sometimes causing hypotension and also causing weight loss, rarely causing ketoacidosis. The most common is causing urinary tract infection, especially fungus, mycotic infection. That's about other options. Anyway, anti-diabetic drugs adverse effects are very important. So kindly go through mechanism actions of various anti-diabetic agents and the important adverse effect. I just within a second I just revise all the point. For example, look here, regarding adverse effect of anti-diabetic drug, can you please recollect which is the anti-diabetic drug having risk of causing medullary cancer of thyroid? Answers: GLP-1 analog, the liraglutide, semaglutide, all the glucagon-like peptide analog, they will activate GLP-1 receptor in the parafollicular C cells of thyroid gland, resulting in medullary cancer of thyroid. Now, anti-diabetic drug causing lung cancer can be Afresa. Afresa, a inhalational insulin may cause lung cancer, but not in use. Then, anti-diabetic drug causing adverse effect of macular edema. Think of pioglitazone. The pioglitazone causes fluid retention, thereby causing edema, sometimes causing weight gain, sometimes causing macular edema. Then anti-diabetic causing UTI, very important. It is SGLT2 inhibitors like gliflozin, all the gliflozin. Anti-diabetic causing upper respiratory tract infections of DPP4 blocker like gliptins, sitagliptin, saxagliptin, all the gliptins. Anti-diabetic causing Fournier's gangrene, external genitalia infection, ulcer gangrene. It is again by SGLT2 blockers. Then, very important, anti-diabetic drug causing adverse effect of osteoporosis, pioglitazone, and SGLT blocker. Among the SGLT blocker reported, Kenam. canagliflozin reported to cause osteoporosis. And pioglitazone very much. That's why pioglitazone is very risky. Be careful while using this in post-menopause. In post-menopausal women, be careful. For treating diabetes in a menopausal lady, be careful while using pioglitazone because of risk of causing osteoporosis. Then, anti-diabetic causing heart failure, very important. For example, pioglitazone, saxagliptin, a DPP blocker. These two are reported to cause heart failure. That's why they are contraindicated in moderate to severe heart failure patients. Of course, we have one drug called rosiglitazone. It was already withdrawn because of causing heart failure. See, the pioglitazone and rosiglitazone are thiazolidine dione derivative. In that, rosiglitazone was withdrawn already because of causing heart failure. Okay, next question. Which of following is an FDA approved treatment for postpartum depression? This type of question is important because it involves latest drug, very important. Options are brexanolone, duloxetine, bupropion, venlafaxine. All the given options are antidepressant, but you should tell which is the one FDA approved drug for treatment of postpartum depression. Answer brexanolone. We will discuss one by one after. I will discuss this detailedly. Before that, one point. Look here. What is the problem in postpartum? Actually, during pregnancy, they have high level of progesterone. Progesterone. The progesterone having very good effect in mental health. They're preventing depression. They're preventing anxiety. So get neuroprotective effects. But immediately following delivery, the progesterone level getting falling down. This may cause depression problem. So for treating postpartum depression, I need some progesterone-like activity. For that, I go for brexanolone. What is brexanolone? It's an actually we have one thing called allopregnanolone. It's an active metabolite of progesterone. Now, what I'm saying, brexanolone is synthetic allopregnanolone. So, when you use brexanolone, it's going to maintain the progesterone level, thereby preventing depression. So, the problem of postpartum depression is due to sudden fall in progesterone level. Thus, we go for synthetic analog of allopregnanolone. Allopregnanolone, a metabolite of progesterone. So, brexanolone, a neurostimulator, going to protect the brain, activating GABA A activity and having very good effect on postpartum depression. It is given intravenous infusion, say 60 hour following delivery, 2.5 days continuously as a IV infusion. But today you should know for treating postpartum depression, I have one more drug, oral drug called zuranolone. The zuranolone also something similar to brexanolone. It is also activating GABA A, useful for postpartum depression. Advantage used orally. That is one tablet per day for 14 days. So 2 weeks therapy. Remember, IV drug mean brexanolone, oral drug mean think of zuranolone for treatment of postpartum depression. Look at the other options in the question. The other option I mentioned duloxetine venlafaxine. Remember, the duloxetine venlafaxines are antidepressant classified under SNRI, serotonin norepinephrine reuptake inhibitor. Here, first question. Duloxetine, venlafaxine, both are useful for treating depression and both are useful for treatment of fibromyalgia, myalgia, body pain. for treatment of muscle pain. Okay, here beautiful point. Look at the duloxetine special word. The duloxetine, in addition to depression, in addition to fibromyalgia, also useful for treatment of diabetic neuropathy pain. Useful for neuropathy. Also useful for controlling to control stress incontinence of urine. That is, a elder age female complaining, sir, even on coughing, even on laughing, even on sneezing, I passing urine. I'm not able to control my urine. In this case, to control the urination while coughing, I can try this. This is going to increases urethral tone. By increasing urethral tone, control urination while coughing. That is duloxetine extra point. Coming to one more option in the question, bupropion. What is this? It's an NDRI, that is norepinephrine dopamine reuptake inhibitor. It's an antidepressant. It's actually antidepressant, useful for controlling smoking. So, point 1, useful to control smoking. Point 2, useful for treating depression. Point 3, useful for treatment of obesity. Point 4, useful in ADHD to improve the attention span. So, bupropion, a antidepressant classified under NDRI, norepinephrine dopamine reuptake inhibitor. Coming to adverse effect, very important. The two most important adverse effect, it causes weight loss. One point, weight loss. Other point, causing anxiety, rarely causing seizure. That's what adverse effect of bupropion. Okay. Coming to next question. Which drug is the FDA approved drug for treatment of for reducing abdomen fats in HIV associated lipodystrophy? Look here. In a HIV patient, when they give antiretroviral therapy, they cause lipodystrophy, thereby causing redistribution of fat in the abdomen. So, to reduce the abdomen fat, we have one drug. What drug? It is tesamorelin. It's a growth hormone releasing factor analog approved for treatment of HIV associated lipodystrophy. Look at the other option, somatropin. It's a growth hormone analog useful for treatment of dwarfism. Useful for treating dwarfism. Pegosoman, a growth hormone receptor blocker useful for treatment of acromegaly. Mecasermin, it's a insulin like growth factor useful for treatment of dwarfism. Anyway, the right answer for question option B. Anyway, just to look at my presentation. HIV with the lipodystrophy. That is, a HIV patient, when given antiretroviral, the antiretroviral drug causes fat redistribution, causing lipodystrophy. To reduce this fat, I can try tesamorelin. It's a growth hormone releasing factor analog. GH means growth hormone releasing factor analog. Next, for treatment of acromegaly, I can give growth hormone receptor blocker. That drug is called pegosoman. Very important. Pegosoman, a growth hormone receptor blocker useful for treatment of gigantism or acromegaly. Okay. Next, for treating dwarfism, there's growth hormone deficiency case. I can try somatropin or somatrum. Also, I can go for mecasermin. Mecasermin, a recombinant insulin-like growth factor IGF analog. The beauty of this drug is it is useful for treatment of Lawrence syndrome. Lawrence syndrome. Lawrence syndrome means here the problem is growth hormone insensitivity. I'm giving growth hormone, even then patient not responding. In that case, I can go for mecasermin, a recombinant insulin-like growth factor useful for managing Lawrence syndrome. And then question number 9, which of the following drug can be used as an antidote for cisplatin-induced nephrotoxicity? Very important, very important. For see, cisplatin causes nephrotoxicity. For controlling this, I have an antidote called amifastin. So answer is option B, amifastin. Whereas mesna useful for treatment of hemorrhagic cystitis caused by cyclophosphamide, and leucovorin antidote for treatment of methotrexate toxicity. Filgrastim, a colony stimulating factor useful for treatment of neutropenia, anti-cancer drug-induced neutropenia. So for this question, I just want to give some extra point. Look here. For treatment of cisplatin-induced nephrotoxicity. Actually, cisplatin anti-cancer drug causing nephrotoxicity. To control that, we give along with mantap. Name the diuretic useful with the cisplatin to control nephrotoxicity. Answer mantap. But the specific antidote. Who is the specific antidote for cisplatin? Mean, think of amifastin. Amifastin. Extra point. Amifastin, antidote for cisplatin to control nephrotoxicity, and it is also a radio protective, that is preventing radiotherapy toxicity. It's a radio protective. Okay. Next, cyclophosphamide and one more drug called ifosfamide. Both are causing hemorrhagic cystitis. They're going to produce one thing called acrolein. This acrolein metabolite, this drug produces a metabolite called acrolein that causes hemorrhagic cystitis, causing hematuria. For treating this toxicity, the antidote is mesna, mercapto ethane sulfonic acid. It is the antidote for cyclophosphamide and for ifosfamide. Next, what is the antidote for methotrexate? Methotrexate, a folate antagonist. For treating this toxicity, the specific antidote leucovorin, also called folinic acid. Folinic acid. Actually, it's a reduced form of folic acid. It is the best drug for treatment of methotrexate toxicity. Once again, doctor, methotrexate undergo renal route of excretion. So, to increases excretion, do hydration and do urine alkalization. So, normally for treating methotrexate toxicity, antidote leucovorin. Supportively, we can enhance excretion of leucovorin through urine by making good hydration and also by doing forced alkalization. Okay. Suppose methotrexate not getting excreted. For example, my patient having kidney failure. In kidney failure, methotrexate get accumulated causing problem. In this case, I can use one thing called glucorbidase. Glucorbidase is going to cause breakdown of methotrexate into inactive form. That is, it's going to enhances metabolism of methotrexate, thereby reduces methotrexate plasma level. So useful for treatment of methotrexate toxicity. See, the specific antidote is leucovorin. Suppose patient having kidney failure where methotrexate not properly undergo excretion, mean we can try one thing called glucorbidase. It's going to enhances metabolism or making more breakdown of methotrexate, thereby rapidly bring down the methotrexate level in the plasma. Okay. Now, we have one drug called doxorubicin. It's an anti-cancer antibiotic. anti-cancer antibiotic. It causes adverse effect of severe cardiomyopathy causing congestive heart failure. Now question starts. For controlling cardiotoxicity due to doxorubicin, the specific drug is go for dexraxacin. Actually, it's a iron chelator. Iron chelator. What Harrison book says, doxorubicin in the presence of iron molecule, they're going to form some free radical. The free radical going to cause cardiotoxicity. So, to control the cardiotoxicity, I need iron chelator, that is dexraxacin. And to control the radical, I can add vitamin E, the so-called tocopherol. Okay, so the specific and dexraxacin adjuvantly we can try vitamin E. Okay. And then anti-cancer drug causing myelosuppression. The myelosuppression, the bone marrow suppression can be either neutropenia or anemia or thrombocytopenia. How to treat this? For treatment of neutropenia, we have one group of drug called colony stimulating factors. There are two type of drugs. One is recombinant G for granulocyte colony stimulating factor. One more thing, recombinant granulocyte monocyte granulocyte monocyte colony stimulating factors. Who are the example for granulocyte factors? Are we having filgrastim, pegfilgrastim, and lenograstim. Peg mean polyethylene glycol. That means when you add peg with filgrastim, it becomes longer in duration action. So purpose of adding polyethylene glycol with filgrastim to make longer duration of action. Okay. What are the example for recombinant granulocyte monocyte factors? We are having sargramostim and malgramostim. Remember, all these colony stimulating factors are useful for treatment of neutropenia, anti-cancer drug-induced neutropenia. Now, anti-cancer drug may cause anemia. For treating this, we go for recombinant erythropoietin like epoetin or darbepoetin. And finally, anti-cancer drug may cause thrombocytopenia. For treating this, we can go for either oprelvecin or thrombopoietin. The most important is oprelvecin. Very, very, very important. Oprelvecin is the interleukin 11 analog. It is the most common drug useful for treatment of anti-cancer drug-induced thrombocytopenia. Okay. Finally, the last question. Which drug is the neurokinin 1 antagonist useful for chemotherapy induced nausea? Come on. Anti-cancer drug can cause nausea, vomiting. Here asking, name the NK1 antagonist useful. Options are ondansetron. Ondansetron, 5-HT3 blocker. Aprepitant, yeah. P10 are called NK1 blocker. Answer B. Metoclopramide, a D2 blocking anti-emetic. Pelnosertan, again 5-HT3 blocker. So the right answer option B. But this type of questions are very important, very important. For example, look here. For treatment of cancer chemotherapy vomiting, we have wonderful group of antibiotic called 5-HT3 antagonist. Actually speaking, anti-cancer drug vomitings are two phase, early phase and late phase. Early mean immediately following anti-cancer therapy. Late mean after 2 days, after 3 days. I given chemotherapy today, 2 days later or 3 days later vomiting. They call late phase. Okay. For early phase vomiting, best choice 5 T3 blocker like ondansetron or pelnosertrom. And what they say, anti-cancer drug causing severe vomiting. So, for better control of vomiting, along with this, you can add some supportive drug. The supportive anti-emetic can be your corticosteroid like dexamethasone, a wonderful adjuvant, a wonderful supportive drug. Anyway, the primary drug of choice for treatment of anti-cancer vomiting means 5-HT3 blocker like ondansetron or pelnosertrom. Whereas, if they asking specifically, name the group of drugs useful for late phase vomiting. For treating late phase mean I need longer acting anti-emetic. They are called NK1, neurokinin 1. NK stands for neurokinin 1 blocker. They are long acting like aprepitant, fosaprepitant, rolapitant, NEETPG, like that. All the patent are called NK1 block. That's why, doctor, usually for treatment of vomiting due to anti-cancer, better go for, before starting chemo, better go for pelenosertron with the dexa with the aprepitant. If you go for this, I can control early phase, late phase, all phase vomiting. Anyway, anti-cancer drug and the vomiting treatment very important. Okay, I just covered the most important questions. This Oscar NEET mock test paper. I think I given all the questions explanation in detail. So it's your duty to revise everything. May God bless you. All the very best, doctor. Thank you very much. Do well. Definitely, God will be on your side. So, I'm praying for you. God bless you. Thank you all. Do well. Thank you. Thank you. Thank you.
Hi, welcoming you for the mock test discussion. First question: a newborn develops conjunctivitis on day 2 of life. Discharge purulent and profuse. Discharge is purulent and profuse. Gramston shows intracellular diplococci. What is the best preventive measure? What is this condition? It is neonatal conjunctivitis. Other name, ophthalmia neonatorum. Caused by gram-negative facultative intracellular diplococci, gonococci or Neisseria gonorrhoeae. Neisseria gonorrhoeae. What is the best preventive measure? Yes, we need to update. Best preventive measure currently, topical erythromycin eye drops or eye ointment we are using, because previously we used silver nitrate irrigation, otherwise called this method is called Creed's method. But now the latest treatment is topical erythromycin eye drops is the latest one. Second question: 5-year-old unvaccinated child presents with high fever, cough, coryza, conjunctivitis and maculopapular rash. Cough, coryza, conjunctivitis. Old case definition. New case definition: fever with rash, maculopapular rash. Started on the face and spread down. Small white spots are noted on the buccal mucosa shown in the image. What is the name of the spot? See here. See the spot exactly. Mark here. All white spot, white lesion in oral cavity. We call it a scoplic spot. We call this as scoplic spot. Scoplic spot you can see in which condition? Scoplic spot we are seeing in measles, rubella, blueberry muffin rash, roseola infantum, 6th disease, Scarlet fever. It is caused by, it produces sandpaper rash, group A beta hemolytic streptococci. Next is a 30-year-old male presents with severe pain, crepitus and swelling over the thigh 2 days after crush injury. Crepitus, gas in the muscles. Okay. There is a brownish discharge with a foul smell, anaerobe. What is the virulent? It's a case of gas gangrene caused by Clostridium perfringens. Gas gangrene. And major toxin is called alpha toxin, lecithinase activity. Alpha toxin, lecithinase activity. M protein, streptolysin O, these people seen in streptococcus, group A beta hemolytic streptococcus. Exotoxin A, classical pseudomonas. Classically pseudomonas. Next is a 38-year-old HIV positive man, CD4 count very low, 45, presents with seizures and confusion. MRI shows multiple ring enhancing lesion. Serology positive for IgG toxoplasma. Which of the following is the best initial therapy? So already it is a proven case of toxoplasma, otherwise ring enhancing lesion. You can think 3 people in HIV. One is called tuberculosis. Second one is toxo, progressive multifocal leukoencephalopathy. Fourth, you can get lot of calcification in neurocysticercosis, but these 3 are common in HIV positive. Already it is positive for toxoplasma. So toxoplasma positive, what is the treatment? Treatment for, because it's a not a pregnancy, positive it's a man. So you can go for pyrimethamine sulfadiazine. Pyrimethamine sulfadiazine. In case of pregnancy, spiramycin. Coccidian parasites, cotrimoxazole sulfamethoxazole, cotrimoxazole, trimethoprim sulfamethoxazole, fluconazole for fungus, acyclovir for herpes. Acyclovir is for herpes. That's all, my dears. Next is 65-year-old hospitalized woman develops severe watery diarrhea 5 days after receiving clindamycin for a dental abscess. Colonoscopy reveals pseudomembrane. What is the best diagnostic test for the suspected organism? What is the case this is? Just you can recollect. Clindamycin therapy, okay, severe watery diarrhea, it is, and presence of pseudomembrane, game over. Pseudomembranous colitis caused by Clostridium difficile. It's a case of pseudomembranous caused by Clostridium difficile. What is the best diagnostic test? See, that is the word is important. Culture is very good test, almost gold standard. Everywhere culture is gold standard, but here just culture will not help, because culture can tell the organism grows whether it is a pathogen or not. That you should decide whether the pathogen or not. So it has 2 type of toxin. Toxin A is enterotoxin, toxin B cytotoxin. Pseudomembrane contains cell debris, fibrin, everything, all due to cytotoxin. Because of cytotoxin we get pseudomembranous colitis. So it is ideal to detect PCR for toxin B gene, because nowadays PCR is gold standard for many infections. Gold standard PCR for toxin B gene, because B is responsible for the pathogenicity. No use of stool gram stain. Second best, if you can go for CCFE agar, because CCFE agar can give the organism, but whether it is producing toxin or not, that is important. Toxin assays are important. Best assay comparing with ELISA, PCR. Next is 5-year-old child from TB endemic area presents with 2-week history of low grade fever, vomiting, irritability, and positive Kernick sign. CNS, it's a meningitis. CSF analysis, glucose is low, 28. Protein is very high, 220. WBC, lymphocytic predominance. And the opening pressure is high. What is the most likely? Viral, glucose is normal, protein is normal, cell is lymphocyte. Opening pressure is normal. Pyogenic meningitis, low glucose, high protein. And we have polymorphonuclear cells, high pressure. Fungal meningitis, glucose, high protein, lymphocyte, opening pressure is high. Tuberculous meningitis, low glucose, high protein, lymphocyte, and opening pressure. Fungus and tuberculosis almost looking similar, but the clue is the child is coming from TB endemic area and low grade fever, vomiting, irritability. Fungal means high grade fever, seizures, many things present. Cryptococcus is common. So it is a case of tuberculous meningitis. I can go for tuberculous meningitis. Next is a 30-year-old passenger on a cruise ship presents with vomiting and water diarrhea on board. Several others on board similarly affected. Is outbreak. Outbreak in ship, watery diarrhea, adult age group. Think of Norwalk virus or norovirus. Norwalk virus or norovirus. Rotavirus is very common in children or infants. Children. Vibrio cholera, rice water stool, not ship. Salmonella, usually they won't cause outbreak like features. Even though outbreak comes, clinical pictures are totally different. It is not related to ship journey, cruise journey. A patient with syphilis develops fever, chills, and myalgia after receiving penicillin. What is the likely cause? Fever, chills, myalgia. It is nothing but Jarris-Hexheimer reaction. Why? Because it is due to the products of Trichoderma pallidum, because the bacteria, the antibiotic destroy the bacteria. Okay, it is due to bacterial products. Endotoxin, due to penicillin therapy, because endotoxin is part of cell wall. When you are administrating penicillin break the cell wall. Beta lactam rings got broken. Once cell wall breakdown, automatically release of endotoxin leads to Jarris-Hexheimer reaction. But allergy due to penicillin is type 1 hypersensitivity. Got it? Right. It is not due to drug toxicity. It is not directly due to drug. The drug kills the bacteria because of the bacterial products it is happening. Which marker best indicates active replication in infective hepatitis B virus? Always we have a question on hepatitis B virus. Here there are 4 people are there. Surface antigen indicates infection. Anti-HBC indicates past infection or chronic infection. Chronic hepatitis. Envelope antigen indicates high infectivity. And marker of replication. Envelope antibody, low infectivity. So high infectivity, marker of multiplication. High infectivity, marker of replication. I can go for hepatitis B, envelope antigen, E antigen. Next is neutropenic patient, chemotherapy, that means malignancy, develops pulmonary nodule on central necrosis. Microscopy from culture shown in the image. See here, you can get septate typhi along with vesicle with phyllites, conidia. It's a classical picture of aspergillus, where there is neutropenia. Number 1, always think of neutropenia, hematological malignancy, and the microscopy. See this microscopy picture, beautiful. This round phyllites, okay, phyllites, conidia, vesicles present, septate hyphae. It's a typical septate hyphae. I can go for aspergillus. Mucor aseptate hyphae, Candida pseudohyphae, Cryptococcus, budding cell with yeast, budding yeast with capsule. Capsule. Presence of capsule. Okay, with this we completed mock test discussion. Hope you all enjoyed. Thank you.
Okay, hello everyone. So we are going to discuss some question on NEET pattern, and you see NEET is just down the corner only now. So before I start this, all the best to all of you. And in NEET, I'll advise you to, you see, any exam you write, you get question mainly from GIT, from trauma, from breast, from thyroid. Of late, vascular disease has become very important. So a little bit about varicose vein, Burgess, and hernia. These are the major topic. You'll get almost 80% question from these topics. So let's start the question. We have discussed all the questions so many times in grand tests and CBTs and NEET predictor and rapid revision, you know. So it's kind of a revision, quick revision. A male patient aged 30 years following a road traffic accident presents with fracture of 4 to 10 rib and respiratory distress. He is diagnosed with what's flail chest? Flail chest by definition is 3 or more ribs are fractured at 2 or more points. So the rib has a paradoxical movement. During inspiration it goes in, rest of chest wall going out, it's going in, and during expiration it goes out. So lung cannot expand because it's not expanding, it's not going out during inspiration. So it causes lung contusion, pendulums and etc. So whenever you have flail chest, separate topic, whenever you have PaO2 less than 60, then in flail chest the treatment is positive pressure ventilation. And if you don't have positive pressure ventilation facility, then you can go 70-80-year-old treatment, rib traction. You can go for towel clip traction, apply towel clip on the rib and give traction to keep it elevated. It prevent retraction of rib, the paradoxical movement of the chest wall, and allows lung to expand. Of course, it's painful, so it's not done anymore. We go for positive pressure ventilation. So what are the indications of positive pressure ventilation in flail chest? These are the indications. The red ones are the important one, which you have to remember. Black you can skip. So respiratory rate more than 35. And rather than 8 and 6.6, in India we don't follow kPa, we follow millimeter mercury. You can remember 60 millimeter of mercury, less than 60 and more than 50 to 55 millimeter mercury. So in these cases you can go for positive pressure ventilation. Vital capacity less than 12 and right to left hand more than 50%, you can skip. I don't think it will be asked. Question number 2, a 25-year-old male presents to emergency with history of road traffic accident 2 hours ago and lower abdominal blow. The patient is hemodynamically stable, abdomen is tender, more on the lower area, and catheter, only few drop of blood came out. Ultrasound showed collapsed bladder and free fluid in the abdomen. Cystogram given below. You see, let me magnify this. Cystogram, so dye going here, bladder, and you can see extravasation in this area. So this is actually intraperitoneal rupture of bladder. This is called flame sign. Flame sign, intraperitoneal rupture of bladder. And all extraperitoneal rupture of bladder can be managed on catheter only without surgery, but intraperitoneal treated by surgery, laparotomy, and repair the bladder tear in 2 layers. Absorbable suture 2 layer. So best answer is immediate laparotomy. Dekho, this diagram will give you some idea. First of all, intraperitoneal rupture can only happen when the bladder is full. A collapsed bladder is like this, and this is the rectum, and this is the, let's say, the black line is the peritoneum. Only when the bladder is full, then the dome of the bladder comes in contact with peritoneum and then can rupture here. So lower abdomen is your full bladder. So rupture here is intraperitoneal 20%, rupture here is extraperitoneal 80%. Extraperitoneal, I told you, can be managed conservatively only on catheterization. Extraperitoneal may give teardrop sign, intraperitoneal gives flame sign. Okay. Intermittent always managed conservatively. It's a typical history. Bladder full, lower abdominal blunt injury, patient doesn't have desire to pass urine, and it is not bacterial peritonitis, chemical peritonitis to begin with, later on becomes bacterial. So pain, guarded tenderness can be there, but more with time. And if you inject dye into the bladder, cystogram, you see leak of the dye into the abdominal cavity, like the picture I showed, flame sign, and immediate surgery. So answer of course is C. And here answer is A. Okay, so question number 3. A 24-year-old male was brought to emergency with road traffic accident. He is conscious and oriented. He is complaining of breathlessness and pain in left upper abdomen. देखो, आप ध्यान से देखो ना तो on the left side you find a kind of air fluid level. What is this? This is actually a diaphragmatic injury and the bowel has herniated up. For diaphragmatic injury, only 4-5 lines you need. Only 3-4 lines will suffice. Just that's MCQ. So pain upper abdomen and lower chest, decreased breath sound, and the images is showing it's not a hydrothorax or hydropneumothorax. It's simple bowel going up. The lung is expanded here. You cannot see broncho marking are visible. It's not a pneumothorax. Okay, this is the air. This is the lung. So 4 lines or rather 5 lines I want you to remember. Diaphragmatic injury are common on the left side, number 1. Number 2, more with penetrating injury. Number 3, bowel herniates up. So late presentation is very common. Number 4, ICD is contraindicated. Don't consider this hydronesis and say ICD. No, ICD contraindicated. This MCQ. Number 5, what is the best investigation? Laparoscopy. Laparoscopy is diagnostic and therapeutic both. That's best. And number 6, surgery is only done from the abdomen. If you want to repair the diaphragmatic injury, don't do thoracotomy, go by laparotomy from the abdomen side. Okay. So left side more common, laparoscopy best, delayed more common. Early ICD is never done. This is rather contraindicated. These are the points you have to remember about diaphragmatic injury. Which of the following is not a feature of proliferative phase of wound healing? देखो, proliferative phase means 3 days onward. Initially there is a hemostasis and inflammation, then proliferation and then remodeling. So in proliferative phase the main cell is fibroblast. They lay down collagen, wound healing is taking place. So fibroblast is main cell, collagen laid down, absorption takes place. Matrix metalloprotein is basically a component of remodeling phase, not in proliferation phase. So initial 24 hours neutrophil, then WBC fibroblast, they become macrophages, and finally they lay down collagen, and 3 day onward proliferation phase. But MMP is basically seen in remodeling phase. Okay. False statement about condition. What is this? What's being shown here? This is keloid. First of all, 2-3 very important point difference in keloid and hypertrophic scar. 2 most important points. Then I'll tell you some minor point. Number 1, hypertrophic scar only it remains confined to the wound, while keloid infiltrates in the normal tissue as well. Number 2, hypertrophic scar can only grow up to 6 months, then becomes static. Keloid grows beyond 6 months. So keloid growing beyond 6 months, number 1, and number 2, invading in the normal tissue. This is a classical feature of keloid. Keloid has a racial predisposition, more common in blacks and colored races. Side predisposition, sternum and upper part of body, ear lobule, sternum, back, familial, and as I said, grows beyond 6 months and into the normal tissue. Hypertrophic scar, none of these feature. And recurrence is higher in keloid. So usually familial, more common in black, upper part of body, and may extend in normal tissue. 2 to 4 weeks is for hypertrophic scar. Keloid is for 3 to 4 months. It grows in months. So this is the wrong answer. Primary cleft palate is, what is the primary cleft palate? Primary cleft palate is cleft anterior to incisive. This is a incisive foramen. So this is a primary cleft palate, this one, and here behind this is secondary, and this is a complete unilateral and bilateral. So primary cleft palate is anterior to incisive foramen. The surgery of cleft palate is done from 12 months to 18 months, usually around 18 months, and cleft lip is done around 6 months, 6 months to 1 year. Although after 10 pound weight, 10 gram hemoglobin, and 10 week age. That's why cleft lip. 10 weeks means around, say, 2.5 months. So 3 months onward we operate. So 3 to 6 months. So cleft lip around 3 to 6 months is fine, but around 6 months, and cleft palate around 1.5 years, 12 to 18 months. Which of the following condition anti-thyroid antibody may not be elevated? देखो, Hashimoto thyroiditis has anti-TPO. Earlier it was called anti-thyroid peroxidase, name anti-microsomal antibody. It is high in 90%. Graves has LATs, anti-thyroglobulin antibody, long-acting thyroid stimulants, IgG. Lymphoma thyroid can be a sequelae of Hashimoto's, although lymphoma, diffuse large cell B cell lymphoma is separate, but it can be associated with Hashimoto's. So here also antibody can be high. While multinodular goiter all over the world, most common cause is iodine deficiency, although there are other causes of congenital enzyme deficiency also. But multinodular goiter is not autoimmune or antibody related. So we will not have high antibody in multinodular goiter. False statement of probability cancer thyroid. Multicentric, yes, 80% multicentric. Summer bodies, yes. Node spread common, yes. Hurthle cell, no. Hurthle cell is a type of follicular. So papillary thyroid, what are the features? This is the most common thyroid cancer, say about 70% onward, 70-75%. Common in female, young age, 30 to 50 years or 20 to 50 years. Radiation is a risk factor. Dekho, papillary has favorable and unfavorable, two types, low grade and high grade. In high grade type, we have tall cell, columnar cell, diffuse sclerosing, and insular. Diffuse sclerosing has the highest association with radiation. We all know radiation risk, low dose radiation, less than 2000 rats is a risk for thyroid cancer, mainly diffuse sclerosing. And the low grade type, tall cell, columnar cell, high grade. Low grade type, micropapillary, encapsulated, follicular, those are called good prognostic cancer. And if you are having follicular and papillary both features in one thyroid cancer, then it is papillary. So features of papillary are not consistent with follicular. Someone having features of papillary and follicular both, then this goes under papillary, and even this is good prognostic cancer, and this is called Lindsay tumor, Lindsay, Lindsay. So Lindsay tumors, papillary and follicular cancer together, considered a papillary cancer, treated like papillary cancer. Papillary cancer has a tendency for lymph node secondary, that's common, that's important. And two more points. Lymph node involvement does not worsen prognosis. Lymph node involvement, prognosis is not affected, number one. Number two, only lymph node involvement without any papillary cancer, that's called occult papillary cancer there and lymph node involvement, then that's called latent aberrant thyroid, which they do us very often. Hurthle cell is a subtype of follicular thyroid cancer. Okay, so that's a wrong statement. And orphan NEI nucleus and summer bodies, these are features of papillary. Summer bodies you also get in meningiomas and serositoma of ovary and papillary renal cell cancer. There also you can get this summer bodies. So wrong answer is Hurthle cell. Histologically, Zellbalen pattern is seen in. Zellbalen is a German word, ball of jelly. This is considered, although very rarely may be found in meningioma, very rarely. It's a pathognomic features of pheochromocytoma or paraganglioma. So this is a tumor of adrenal medulla, pheochromocytoma. So these are basically balls of jelly, called balls of jelly. So Zellbalen is pathognomic for pheochromocytoma and paraganglioma. As I said, rarely found in meningioma, very, very rarely. And it's characterized by chief cell, neuroendocrine cell, and surrounded by sustanuclear cells and fibrovascular stroma. Pheochromocytoma as such is an important topic for your exam, and I'd like you to read it thoroughly. I'll just tell you some salient point here. Pheochromocytoma में जो सवाल आता है, देखो, it's called 10% tumor, adrenal medullary tumor. And I'm sure you know this is the adrenal. Let's say this is the adrenal. It has two parts, cortex and medulla. Outer cortex and the medulla. Cortex is 90%, mesodermal in origin, medulla is 10%, neuroectodermal in origin. Cortex has three layers, GFR, zona glandullosa, zona fasciculata, zona reticularis. Glandullosa produces mineralocorticoid, aldosterone, fasciculata glucocorticoid, and reticularis sextroid. We are discussing medulla, this part, which produces category epinephrine, norepinephrine. So adrenal medulla produces more of epinephrine, whilst sympathetic ganglion produces norepinephrine. So adrenal medullary tumor is called pheochromocytoma, called 10% tumor. 10% bilateral, 10% familial, 10% children, 10% malignant. So certain familial condition, it may be found. Certain familial condition, like MEN 2, like neurofibromatosis 1, like tuberous sclerosis, like so certain condition can be found. And in treatment, you have to classical presentation, hypertension, paradoxical, paroxysmal, kabhi zyada, kabhi kam. So hypertension, sweating, palpitation, all sympathetic feature, palpitation, sweating, hypertension, headache, palpitation. These are called four cardinal feature. Diarrhea you don't get here. Sympathetic causes constipation. This is a question they ask. Wet feature not seen in pheochromocytoma. Diarrhea you don't get. You get constipation. And first you go for alpha blocker. You cannot operate unless you block the stimulation. So first alpha blocker, furoxabenzamin, then beta blocker if palpitation is still there, and then surgery. So first alpha, then beta. Never give beta first, otherwise alpha action become unopposed. Patient goes in malignant hypertension. So first alpha, then beta, then surgery. So zelberline is a feature of pheochromocytoma. Which of the following is not an X-ray finding of hyperparathyroidism? Ground glass appearance of 2/3 of the skull, calcification of basal ganglion, subperipheral middle phalanx, and this is the first feature actually. First feature is subperipheral absorption of radial aspect of second phalanx, radial aspect, and reabsorption of proximal long end bone. What you don't get is calcification of basal ganglion. This is a feature of hypoparathyroidism, not hyper. This is a feature of hypo. So the bone features of hyperparathyroidism are, number one, see here, subperiosteal reabsorption of the second phalanx on the radial aspect, This is the first feature and very important feature. Then brown tumor, osteoclastomas in the jaw or in the phalanx. Then floating tooth. The cement around the root is gone, so it looks like foot. Then loss of lamina dura in teeth. This radiolucent part is gone. Loss of lamina dura. Then rugged jersey vertebra. And finally, solvable appearance of skull. All these are features of hyperparathyroidism, bone features. Basal ganglion calcification is hypoparathyroidism. In a patient of thyroidoscosis, T3, T4, TSH are elevated. He is having bitemporal hemianopia. Best investigation for this patient. Actually, this is not a question of surgery. It's a part of surgery, more of ophthalmology. So we all know, like these are the two retina, optic nerve, optic chiasma, optic tract, and finally optic radiation. So the medial part of fiber, retinal fiber, they cross nerves, while lateral they simply go like this. So when there is any pituitary, and first of all T3, T4 is elevated, but TSH is also elevated. If TSH is elevated, it means the problem is in the either hypothalamus or pituitary. It's not a primary thyroid problem. Because if T3 is elevated, then TSH should be suppressed if it is thyroid problem. TSH elevated means it's a pituitary problem. Pituitary present in Selatushka presses optic chiasma, it presses here. So this green part is gone. And the vision of this side and this side gets affected. So both side temporal field gone and this is called bitemporal hemianopia. So now I'll order MRI brain. We'll not discuss about thyroid because TCSH high means it's not thyroid problem. If this nerve is injured, then of course one eye will be, vision will be gone. If injury here, then on one side temporal, one side nasal, called homonymous hemianopia. But here the problem is here, like this, bitemporal hemianopia, because this part is getting compressed here. So this part is having problem, bitemporal hemianopia. So we'll order MRI brain. Most common, and if it is here, then it will be temporal, and so this fiber will be here. So this side nasal, this side. So we call it homonymous hemianopia. Most common flap used after radical dissection. देखो radical dissection में क्या होता है कि you remove the sternocleidomastoid, so it's exposed and you are only covering with the skin. And if you are planning radiotherapy post-operatively, then you can have carotid blowout also. Carotid gets ruptured, so you have to give a cover of muscle. Most common two flap that we use. This is most common, which is a myocutaneous flap. Muscle is also utilized, pectoralis major, and this is second most common used flap, which is a fasciocutaneous flap. Muscle is not being used. So this is the most common used flap, which is based on thoracoacromial artery, while this is based on the pectoral branch of internal mammary artery. Second, third, fourth pectoral branch of internal mammary artery. This is the flap we use here. Take it. This is the thoracoacromial artery, and this flap will be taken here, covering the whole area. Pec major flap, pectoralis major flap. A 25-year-old lady presents with a spontaneous. देखो, the lines are important here. First of all, age. So this is a relatively young age. So don't think of cancer. We can have cancer, but think of benign condition first. 3-month duration and discharge from a single duct. Single duct discharge in a young female is invariably duct papilloma. If discharge from multiple duct, then think of cancer. Single duct is duct papilloma. So most common is duct papilloma, that's correct. Microdocectomy is the operation of choice. Basically that particular duct you identify and remove out about 3 centimeter duct. Almost all papilloma are within 3 centimeter. Galactography, injected eye, take X-ray, you can do. Mammography, you can do. Mammography at this age, not done. So galactogram you can do, but it may show the lump filling defect also. We don't do this. And ultrasound can only show, high frequency ultrasound can only show duct papilloma when they are more than 3-4 millimeter. Otherwise, they will not show. So this again is not very good. So it's more of a clinical diagnosis. While blood discharge from multiple duct is not due to papillomatosis, it is due to cancer. So the wrong statement is D. A patient presents with breast cancer, stage T4B. Breast cancer and oral cavity cancer, these two cancer I want you to memorize very by heart, you can say very thoroughly. And other important cancers are in GIT, colorectal cancer and gallbladder cancer. In urology, kidney, prostate and testis, and skin cancer, squamous cell cancer and melanoma. And melanoma both Clark's and Bristow. And thyroid and lung also if possible you remember, otherwise at least this much you have to remember. So T4A is muscle involvement, and in muscle pectoralis major and minor are not involved. This very commonly they ask, only serratus anterior, intercostal and ribs are involved. T4B, skin involvement. In skin involvement, peau d'orange, satellite nodule and malignant ulcer, these are included. Teething of skin, dimpling of skin, retraction nipple not included. T4C, both. T4D, inflammatory breast cancer. Where you have more than 1/3 of surface area of the breast having cellulitis type picture. So nipple retraction is not included. Ulceration over the tumor. Actually, this question is not good because edema as such is not the right word, although edema will lead to peau d'orange. So whenever you have breast edema, usually subdermal lymphatic block, then we do have PUD orange. Satellite needle skin ulceration, yeah. Ulceration not due to pressure necrosis, malignant ulcer. But nipple retraction is not, neither nipple retraction, nor dimpling, nor teething of the skin is included. After application of POP cast for 2 days, a thin built young, the application of POP cast over abdomen for a spinal injury. Patient having bilious vomiting, young patient, thin built patient, bilious vomiting. The superior mesenteric artery goes here like this, and aorta is behind the duodenum. So this is the aorta, this is the artery, and the duodenum is here. After application of abdominal cast, oh sorry, it's behind me, so I'll put it here. Here. This angle becomes narrow and duodenum gets compressed between aorta and superior mesenteric artery, causing bilious vomiting, mainly seen in young thin patient. So this is actually duodenal obstruction called superior mesenteric artery syndrome or Wilkie syndrome. Superior artery syndrome or Wilkie syndrome. Okay, so whenever abdominal cast is applied and thin patient gets bilious vomiting, think of this condition. Third part, duodenal obstruction between aorta and superior mesenteric artery. Which segment of liver takes supply from both right and left branches of portal lymphatic artery? That segment 1 called caudate lobe. Cauda means tail. You can see here, this is left and this is right. Left is 2, 3, 4 segment, right is 5, 6, 7, 8. And right will take branches of from the right side only, left from the left side. So, right portal lymphatic artery bile duct, it supplies right, and left portal lymphatic artery bile duct supplies left. But segment 1, which is called caudate lobe, it takes supply from both the sides, as well as all segment drains into hepatic vein. Segment 1 drains into IVC. Segment 1 drains into IVC, not to hepatic vein. Okay. So segment 1 takes supply from both the sides. Caudate lobe. A patient presents with Charcot side. Ultrasound showed gallstone and dilated CBD. Well, this question is basically a cholangitis. Charcot side means cholangitis. It simply means this is the liver. There is gallstone and dilated CBD more than 8 millimeter. If someone is having cholangitis, that is pain, fever and jaundice, which is Charcot side, means the pathology is the CBD and this bile getting infected. Gallstone only presents with cholecystitis. Cholangitis, dilated CBD, obstructive jaundice, high alkaline phosphatase, all these are suggestive of CBD obstruction. So, if I ask what investigation you order, I'll say MRCP, but here you don't have to investigate, you have to treat. You have to manage the cholangitis. So, simply do ERCP and drain the bile from the CBD and it gets relieved, the septicemia part is over, then we can do cholecystectomy. So, ERCP should be done immediately as a semi-emergency and then later on we do cholecystectomy. Okay. False statement on Melly-Weiss syndrome. देखो Melly-Weiss tear basically is a longitudinal tear here below the GE junction where I have placed the red mark at the right cardia, below G junction at right cardia, caused by retching or vomiting. Very important cause is alcoholic binge. Although anyone having forceful vomiting can have this. Alcoholic binge is most common cause, but pregnancy, sliding hypertonia, forceful vomiting, all can cause this. So, alcoholic binge causing a tear at the right side cardia below G junction is barotrauma, pressure trauma, Melly-Weiss tear. And this presents with bleeding. Remember, Melly-Weiss tear is a partial thickness tear. Only mucosa, submucosa deep, not through and through muscle deep. So, only partial thickness tear. And left gastric artery bleeds. The artery next to this area is left gastric artery. and managed conservatively. Rarely you do sclerotherapy. More than this is not needed. More than 90% melee device tear heal by themselves. 5-10% may require sclerotherapy. So, if a question says there's a melee device tear, base is clean and hematomas is stopped, what you do now? Observation. Mainly caused by vomiting, etching is fine. Mucosa submucosa deep fine. Hematoma symptom fine. Surgery is not indicated, just conservative and at the most sclerotherapy. So D is the wrong statement. And this is a melee device tear. You are looking from the foot end. This is right, this is left, and just a tear on the right side. So sclerotherapy, clipping, all this can be done. This is another melee device tear on the right side. A chronic alcoholic patient presents with abdominal pain, radiating to back, acute pancreatitis suspected, which is not a prognostic indicator. देखो pancreatitis में Glasgow score, Apache score and Rancis. These acute, these three I want you to remember what parameters are included in this. Don't remember the value. If your memory is okay, you have read thoroughly, you have time, you can read values of Ranson's score, but Glasgow Apache, no need to discuss value, only remember the parameters. Hypocalcemia definitely is a important indicator because pancreatitis leads to saponification, and with saponification, calcium is utilized in saponification. More fall in calcium, poorer the prognosis is. Less than 8 milligram calcium is considered poor prognostic. Hyperglycemia again is considered poor. When it's more than 250 milligram %, we consider poor. LDH more than 350 unit is also poor. Remember lipase and amylase. Both are only and only, both are written amylase. So amylase and lipase, both are only and only used for diagnosis. And when you said pancreatitis, when the value is more than 3 times above normal value, more than 3 times more than normal, above normal, it has no role in prognosis. High amylase, in none of the scoring system it's used. So high amylase is not poor prognostic, low amylase is not good prognostic. So it can very well. All of the following are major complication of massive transfusion except more than complete blood transfusion in 24 hours is massive blood transfusion. Hypokalemia you don't get. Why you get hyperkalemia? Because RBC are old, lysis of RBC leads to potassium release. So hyperkalemia you get, not hypokalemia. Hypothermia is a common problem. Hypomagnesemia and hypocalcemia because citrate in the anticoagulant in the stored blood chelates calcium. So calcium low, magnesium low, potassium high, this is a classical feature. Other than this, patient can have alkalosis. Initially acidosis because the ACD medium is acidic, but when you do massive transfusion, then acidosis is not the problem. The citrate goes to liver and gets converted to bicarbonate. So citrate in liver becoming bicarbonate causes alkalosis. And consumption coagulopathy. 5 and 8 have a relatively shorter half-life, they get destroyed very fast. So because the stored blood having less clotting factor, consumption coagulopathy can be there, and TACO and TRALI are two more problem of blood transfusion you can get. Transfusion associated acute lung injury and cardiac overload. So these also. So hypokalemia you don't get, what you get? Hyperkalemia due to RBC lysis and release of potassium. Patient with BPH underwent TURP due to large prostate. The procedure time was 1.5 hours. 6 hours after TURP, patient developed altered sensorium. What's the most probable? देखो क्या होता है कि this is the bladder, this is the prostate, and this is the sphincter. Here is the verumontanum. Verumontanum is landmark. Don't come proximal to verumontanum, below the verumontanum. Otherwise, you can damage external sphincter and cause incontinence. So you pass a resectoscope and start cutting here like this and remove the bit by bit, chip by chip, and you remove. Don't come proximal to verumontanum. This surgery is underwater cutting. You are using a fluid and cutting, and the cutting is done with cautery, with electric current. So I cannot use saline because saline has sodium and chloride ion, and I'm using electric current. No matter how much you increase the power of machine, you will not cut the tissue because electric current gets dissipated in iron. So saline cannot be used. 5% dextrose and distilled water. They don't have saline, iron. 5% dextrose will increase the risk of infection, and distilled water will cause water intoxication, dilutional hyponatremia. You are adding water into the blood, blood gets diluted, sodium value will fall, and that's called dilutional hyponatremia, water intoxication. So distilled water is avoided. Although some centers we used to use this 30-40 years back, when glycine was very expensive, distilled water was used and quickly surgery was done, but now we don't use that anymore. We use 1.5% glycine, which is having no iron, no sugar. Osmolarity is around 170, 180. Blood osmolarity is 280, 300. So it's less than blood, but still somewhat isosmolar. So glycine is considered safe, but there are two problems. One problem still is dilutional hyponatremia, like you are adding water and fluid without sodium, so sodium gets diluted, blood gets diluted. Number two, the glycine goes into the liver, gets converted to glycolic acid and ammonia. This ammonia will cause hyperamonic acid like encephalopathy. So patient has irritability or maybe flashing of light and all this. But good part is that this gets washed out by itself. This ammonia you don't have to treat, just give supportive treatment. In a day or two, patient becomes normal. But dilutional hyponatremia, like water intoxication, patient having headache, bradycardia, hypertension, watery vomiting, and high urine output, water, all this should be managed by sodium supplementation. Sodium correction should never be done rapidly, otherwise that can cause central pontile malnolysis. So hyponatremia is a problem, dilutional hyponatremia is a problem of TRP, which is why the surgery is recommended time is 1 hour, and when you hang the fluid you are irrigating, don't keep it above 60 centimeter. So 1 hour and 60 centimeter height from the patient, these 60 centimeters, 60 minutes, and gram 60 gram. TRP we avoid above 60 gram, then because the size is bigger, then people prefer laser, holmium laser enucleation prostate. So hyponatremia is the most probable diagnosis here. And don't correct the sodium rapidly, otherwise patient can develop central pontine malnolysis. A 60-year-old male on CT scan was found to have a solid tumor involving the inferior vena cava and renal vein. The tumor was within Girota's fascia. All of the following can be done except chest X-ray. Yeah, we do chest X-ray. Preoperative radiotherapy. Neither preoperative radio nor postoperative radio has any role. Radiotherapy is not used in kidney tumor. Chemo also is not good, but yeah, adjuvant chemo we do give and palliative chemo we do give. But as such, it's not chemo responsive. IVC invasion is not inoperable, it's considered operable, and period biopsy is not. You are not allowed to open Girota's fascia. So neither by FNSC nor by biopsy nor in surgery, don't open Girota's. The kidney is removed in toto along with Girota's fascia and so kidney is removed in toto along with Girota's fascia and with penetrating fat, ureter till bifurcation of common iliac, this much you remove. So Girota should not be opened. So biopsy is not indicated, that's correct. But IVC invasion is not inoperable, it is considered operable. See, the IVC involvement is T3. So this is the kidney, this is the Girota's fascia, and this is the perinephric fat. Adrenal is also within Girota's fascia. This is adrenal within Girota's. This is the renal vein, and diaphragm. So when the tumor is in the kidney within 7 centimeter, T1 can be divided into 1A, 1B, less than 4, 4 to 7. More than 7 centimeter is T2. Again divided in A and B, 7 to 10, more than 10. If the tumor goes in perinephric fat, that is T3A, going in renal vein, thrombus, T3A. So perinephric fat outside kidney within gerotas is perinephric fat T3A and renal vein thrombus T3A. If the thrombus goes in IVC but below the diaphragm, that is T3B, and above diaphragm T3C. Remember, all these are operable. IVC invasion or thrombus in RCC is not an inoperable criteria, it's considered operable today. And adrenal is within the gerotas, so it was considered T4 in the it was T3 in the past, but now adrenal is considered T4. In new ages classification, adrenal is T4. Okay, so IVC invasion is not inoperable, it's operable. We do have a classification based on IVC invasion RCC called NEVES, N-E-V-E-S, NEVES classification. Although I doubt कि आपसे पूछा जाएगा, so NEVES is not important for you. I mean, for MS etc. it may be asked, but not you. NEVES basically is what? This is the diaphragm, and this is the hepatic vein. This one, hepatic vein. So tumor in the renal vein is 0. In IVC, less than 2 centimeter 1. More than 2 centimeter, but below hepatic vein is 2. And above hepatic vein, above diaphragm 3 and 4. So NEVES is basically based on the how much thrombus extent is there in the venous. But only remember the name if you want to remember. Nobody will ask this, so don't worry about it. A 52-year-old male, a case of NHL, receives first cycle of chemotherapy with CHOP 10 days. He presented to casualty with complaint of muscle twitching, cramp, carpal spasm, paresthesia. His initial investigation revealed hyperkalemia, hyperphosphatemia, hyperuricemia. What is this condition? This is a tumor Lysis syndrome. Chemotherapy, especially in rapidly proliferating cancer, too much of potassium, all this uric acid, etc. release, and they can cause acute renal failure also. You have to manage this. Sometimes you give rasburicase, not given in uric acid more than 8, not given in GC's PD deficiency. Don't go for alkalization of urine, otherwise patient can develop calcium phosphate stone. But high urine output and all those things, no alkalization, and rasburicase you can use. So this is a classical tumor Lysis syndrome. Vascular disease has become very favorite, either Berger's or varicose vein, classification, treatment, etc. they do ask. Lipodermatosclerosis is T4B. So this is CEAP classification. T0 no visible vein, T1 tenacious less than 3 mm in diameter, T2 varicose vein, T2R, C2R is very recurrent. Recurrent is a new addition. Edema, pigmentation, eczema, C4, lipodermatosclerosis, like here. Lipodermatosclerosis. Champagne bottle sign. This is called champagne bottle, inverted champagne bottle sign. And corona phlebectatia, C4C. Healed ulcer, C5. Active ulcer, C6. Recurrent active, C6R. C6R, this, C4C and C2R. These are the new addition. And they do ask classification very commonly. All of the statement regarding surgical needles are correct except the end of the needle with suture is embedded in the needle is called swatched end. Needle should be ideally held at anterior 2/3 posterior 1/3 junction. Needle length is the linear distance from point to the curved needle to swatch. And I mean what he is saying is that this is the needle, curved needle let's say, and this is the suture. The needle length is this, here to here, and the cord length is this, from the tip to swatch end. So it is not a linear distance from curved end needle to swatch. That's called chord length. So this is wrong, and cutting and reverse cutting needle should be used for suture. Of course, for fascia, for suture, you use cutting and reverse cutting. देखो, ये होती है normal needle, which is called eyed needle. They have an eye. You thread the suture through the eye. And here the suture is embedded like here. Suture is embedded in the needle, no eye. They are called atraumatic needle or eyeless needle, atraumatic needle, and they are swatched end. Number 2, this is swatched, eyeless atraumatic needle here. Number 2, needle should always be held from anterior 2/3 posterior 1/3 junction with the tip of the needle holder, and the movement should be at the wrist. You have to go for, not go straight, go circular movement, and from the tip of needle holder, anterior 2/3 posterior 1/3. Number 3, the needle should pierce the skin at 90 degrees. So needle is curved, don't enter obliquely, enter at 90 degrees and then curve the wrist and move the needle. This is a MCQ asked 2-3 years back. Needle should pierce skin at what angle? 90 degrees. And number 4, this is the cord length from here to here, and this is the needle length from here to here. Normally they ask more question on suture, less question on needle, but they do ask question on needle also. So that's it, some 25 questions. I think urology, thyroid, breast, trauma, GIT, vascular and hernia. Give emphasis to these topics. You'll have 80% question from these topics. Okay. So that's it for this particular session. All the best to all of you. Thank you.
Hello everyone, let's discuss the anatomy questions over here. So this was question number 1, and there is a mark structure. What is the mark structure? We can see over here, that is the corpus callosum. I hope you remember the corpus callosum over here. This is the fornix. In between we have the septum pellucidum, but the marker is on the posterior part. That's the splenium part, because that is the genu, the rostrum, the body, and that's the splenium part over here. Now the splenium, they are asking what's the blood supply, and among the choices we'll definitely go with the answer B. Why? Look at this image and you can see this is the territory of the ACA, this is the territory of the PCA. Splenium is at the territory getting supply from both the sides. So that's why answer will be that ACA plus PCA. Now the question is, which of the following reflexes test the integrity of the nucleus ambiguous, which is a compound nucleus for the 9th, 10th and 11th nerve? Looking at these options, straightforward answer is the gag reflex. Why? Because here we have the afferent 9th nerve, efferent 10th nerve. Jaw reflex is mediated between that's the like mandibular nerve only, which is involved. Stapedial reflex is basically we are looking at the 7th nerve. Part of the 8th nerve is also there because of the auditory reflex will come. Okay, and like we have the 7th nerve then, which is the nerve to stapedius, which is going to mediate. Cordial reflex is between the ophthalmic division of the trigeminal nerve and the 7th nerve. So definite answer is C. There is no doubt about that. Now this question is basically very basic question, although the history has been given this as experiment and this and that. But the dorsal horn, when they are saying dorsal horn means what? We are looking at sensory horn, because we will know. How do you remember? काम करने के लिए आगे बढ़ते हैं. We move forward to do something. Doing something is motor activity. Forward is like anterior, like ventral. So anterior and ventral will be motor. Dorsal and posterior will be sensory. So we are looking at the sensory nuclei. ठीक है? But in the alar plate or the basal plate, A for alar, A for afferent. So जितने भी sensory और afferent होंगे ना, वो alar plate से आएंगे. That's why answer is A. This muscle is given, which is nothing but the rhomboideus major. That's rhomboideus major. And the question says about the action. What will be the action? It can do the retraction. First of all, you remember this, because if they ask a single best answer, answer will be retraction. Rhomboideus plus trapezius. That's why R and T capital. then they can elevate also, but elevation is not happening in this direction, it is happening in this direction. If the elevation in this direction, the glenoid will face downward. That's why we are looking at retraction, yes, elevation, yes, rotation, yes, but the glenoid will tilt upward, no, rotation with the glenoid cavity downward. So A, B, and D, that's our answer. Next question is this lesion of which will lead to the Fraze syndrome. Now we know the Fraze syndrome is basically what really happens. We are looking at the nerve, which is like the nerve supply of the parotid. Look at this part. We have the parotid over here and the skin over here, right? So we can say, like, if I draw this way and explain that we have the parotid and we have the skin. For the parotid, we have auriculotemporal nerve, which is going to supply over here. And for the skin, we have great auricular nerve, which are going to supply over here. Gland is secreting the saliva and the skin for the sweating. By chance, this nerve got injured and it goes and merges with this. So auriculotemporal ka regeneration poor hai. Regeneration is like not proper. So if they ask which nerve is involved, actually both the nerves are involved, auriculotemporal and the great auricular nerve. But if you have to choose one, definitely auriculotemporal nerve will be the answer over here. And what will happen in this case when the auriculotemporal nerve is activated for the salivation, like for the time of having food, gustatory part, right? But what really happens is the sweating. That's what is called as gustatory sweating. Okay? That's the Fraze syndrome. Auriculotemporal nerve is involved here. And A is the auriculotemporal nerve. That's why A is our answer. What are the other nerves? We can just go through like this. This is the deep temporal for the temporalis muscle, buccal nerve, which will pierce the buccinator, but it will not supply it. And the nerve to mylohyoid, you can see the floor of mylohyoid, which will supply the mylohyoid, also supplies the anterior belly of digastric. So that was all. Dear friends, thank you so much. Take care. God bless you all.
Hi guys, good morning, good afternoon and good evening. Welcome to the discussion of NEET mock PSM. Guys, I hope you understand that the NEET PG is around the corner now. It's hardly 10 more days to go, and you should understand that by this time, whatever score you are replicating in mock, you will almost get a similar score in the main exam. But again, please try to understand, I am saying the word similar, it is not same. So there is always a window of opportunity to actually get plus 50 to plus 75 marks from this particular score, and that only requires exam day presence of mind, no anxiety, a cool mind setup like MS Dhoni probably to say, if you actually are looking to nail the exams. Yes guys, so let us have a quick discussion of these 15 questions. NEET gives you around 20 to 25 questions in PSM, from which we expect a 95% accuracy from your side to get the questions right. Yeah. First question. A study is comparing the effectiveness of 3 different weight loss drugs. 3. By measuring the mean weight loss in kilograms among the 3 independent group of patients, which statistical test is most appropriate to compare the means across the groups? Now, all of us know by this time that for questions on statistical test, we need to have a 4-step approach. The first step, number of groups, more than 2. Second, paired or unpaired? It is unpaired. The output variable is mentioned as mean, so it is quantity. So we go for the algorithm 2, and you know in algorithm 2, if there are more than 2 groups, answer would have been one way ANOVA. When the answer would have been chi-square, if it would have been quali data. Paired, if the data would have been paired. And t-test, that means it should have been 2 groups. Again, Fisher exact, when it would have been quali data. So Fisher exact and chi-square actually are done for quali data, but when do we do Fisher exact specifically? When in the 2 by 2 table of chi-square any value is less than 5. Yes guys, This is a bread butter question of the NEET PG statistical test. Last year also in NEET 2024, in both the sessions there was a question. This year also in the January FMGE exam and the INICET exam of May, there was also a question on this particular topic. Okay guys? Now, a healthcare facility is reinforced to withstand the seismic activity by retrofitting its structures according to new building codes. Okay? Which phase of the disaster cycle is this action an example of? Now let us look into the disaster cycle. In the disaster cycle, we have the disaster impact. Next, we have the response and relief, where we look into triage. Next, we have rehab. If there's a wound, we will be going for a plaster. If there is a wound, we'll go for a suture. If there is a fracture, we'll go for a plaster. This, my dear students, is done post-disaster. Now, in the pre-disaster phase, we have the mitigation. Now, what is mitigation? Mitigation means lowering the impact by having earthquake resistant buildings. This example, my dear students, is a classical example of a earthquake resistant building. Yes guys. After mitigation, we can go for mock drills. If you remember, on the 7th May this year, a war drill was announced in India. Yes. So this is a disaster cycle. So answer to this question. Now we are talking about mock drills. Yes. So mock drills would have been preparedness. Here we are looking for your structure according to the new building code. Yes. So this basically goes for your mitigation. So answer to this question was mitigation. Yes guys, answer to this particular question was mitigation. I hope I am clear with this. Done. Lowering the impact so that it can withstand the seismic activity. I hope I am clear with this. Done. Over. Great. Measles outbreak occurs in a refugee camp shortly after a cyclone displaces thousands of people. Many children are under immunized. What is the best public health intervention to control this outbreak? Now they are talking about a measles outbreak. So quarantine of affected families. Now guys, measles has got a very high secondary attack rate. So quarantine will become only for the apparently healthy individual, which is very difficult to pick up in this particular setting. Immediate mass measles vaccination seems to be a good option because the measles vaccine can be used as a post-exposure vaccine within 2 days of exposure. Immediate fever screening at camp entrance? No. Distribution of antibiotics and antivirals. Measles does not have a potent antibiotic or a antiviral. Yes guys. So measles vaccine becomes the best answer for post-disaster vaccine to the patients. Following an earthquake, a hospital receives a surge of injured patients. A woman arrives with an open femur fracture but is hemodynamically stable, okay, and is alert. That means there is not a critical stage. You can label the person as yellow. And in yellow, you will give the treatment within around 24 hours. Red, immediate, life-threatening, 4 to 6 hours. Green, ambulatory patients. Black people are generally those who are dead or are almost in a vegetative state. A patient recently diagnosed with cancer becomes tearful and withdrawn during a consultation and avoids eye contact with the physician. What type of communication barrier is this most likely to be? Now guys, first and foremost, it is at an individual level. It would have been an environmental barrier if it would have been noise. Here, there is no such noise. Now, semantic barrier is when basically there is some language barrier. Here, the patient is mentally disturbed because he or she has been diagnosed with a life-threatening illness. So this becomes a psychological barrier, and that is the reason, guys, whenever we have to tell someone about such a life-threatening illness, we follow the spikes protocol. So spikes protocol is basically used to break the bad news to the patients. I hope I am clear with this. Now, after the cyclone, UNICEF provides water purification tablets, builds latrines, and promotes hygiene education in refugee camps. Which area of UNICEF's intervention does this activity fall into? Okay, so UNICEF, generally we know about GOBI-FFF. Growth monitoring, oral dehydration, breastfeeding, immunization, family planning, food supplements, female education. But guys, this is the major function of UNICEF. There are some other functions also which we have to read in this question and pick up. So nutrition, no, not exactly. No education, water, sanitation and hygiene. Yes. Guys, this question was not about a theoretical one. It was all about reading the question and understanding the options and selecting the best one. In a rural community, the health workers use posters, school presentation and home visits to promote hand washing with soap. Okay, this approach is best described as policy enforcement. We are not forcing someone. Medical intervention, there is no medicines. Behavioral change communication campaign. Yes. Again, guys, this question is a typical question where you have to read the options and get the right answer. In BCC, we follow something called as ETA. So the people become aware that there is hand washing. Yes, the people show interest that they would prefer to wash hands. They will evaluate. They would try for the first time. And finally, they will adopt. I hope I am clear with this sequence of ETA. Yes. Now, during rounds, you observe that the soil dressings from a wound are being placed in the same bin as general waste, soiled dressings in a surgical ward. Which color code bin should the soil dressing be disposed according to the standard biomedical classification? Soil dressing typically goes into the yellow bag. Non-biohazard goes into the black bin. Red, anything you want to recycle, it goes into red. Blue is basically for metallic implants and glasswares. Yes, guys? Okay. Question number 9. Identify the stage X. And this, my dear students, is the family cycle. Family cycle has got 6 stages, but here the examiner has made only 4. No problem. So first the family will form, a person will get married, then there will be extension, the first childbirth. Yes, there is dissolution. Then definitely over here the stage is contraction. So after extension there is complete extension, after contraction there is complete contraction, and then there is dissolution. Answer to this question was contraction. I hope I am clear with this. This, my dear students, is the 6 stages of demographic cycle. Generally, guys, in your exam, you get a question to arrange these steps in a sequence. Yes, guys? A factory worker diagnosed with asbestosis seeks compensation under the Employee State Insurance (ESI). Pneumoconiosis is classified under which category of the occupational health legislation? It is not a communicable disease. It is not a lifestyle disease. It is a notifiable occupational disease. Remember, there are 34 diseases which are notifiable as per the Factories Act and ESI. In this comes all occupational cancers and all pneumoconiosis except bagasosis. bagasosis, which is caused by sugarcane. A physician analyzes the annual income of patients in a rural health survey and finds that a few extremely high income skew the data. Which measure of central tendency should the physician use to represent the typical income? Now there is a skewed data. Because there is a skewed data, this becomes a median. Median is typically used for outliers. A health officer notices a sudden increase in the case of diarrheal diseases after flooding in a village and starts actively visiting the households to collect the case data. What type of surveillance is described here? Now here the health worker is visiting the home of people. This, my dear students, is called as active surveillance because the health worker is visiting home of people. Yes guys? In a district hospital, the stock of adrenaline injections is critically low. This drug is essential for managing anaphylactic shock. How should the adrenaline be classified under VED? Now, VED, vital, essential, desirable. Adrenaline is a vital drug. You cannot expect a shortage of this particular drug ever. I hope I'm clear with this, guys. No problem. What disease does this vector cause? This, my dear students, is soft tick. Because you can see the back is absolutely soft. This typically causes Q fever. Guys, the diseases caused by different vectors are a very, very important topic if you look in the exam. Now, what does this image provide? Now, you can see there are scatter or dots. So trend lines, this is provided by the line diagram. Geographical distribution, this is provided by the spot map. So this, my dear students, tell you about the relationship. Relationship is typically seen by scatter diagram, which is seen by correlation. Discrete data, for this we will have bar or pie. This, my dear students, is all about the discussion of the questions of the NEET mock. Guys, if you have any queries, any doubts, please do not hesitate to reach out to me on my WhatsApp number. This is your host, this is your dost PSM said. All the best guys for your exam. Remember, in PSM, except for one question in the exam, you would be able to answer all what you have read from your notes. So do not panic. PSM is a high scoring subject and you are going to rock the exam. Love you all guys. Post exams, let us all catch up and have a gala time together. See you.
ENT segment. So beta, the first MCQ I have taken from your PYQ section 2022. They ask you this MCQ, which is very close to the base of the cochlea. High frequency hearing loss is due to the damage to the basilar membrane. Now, what is the catch in the MCQ? They are giving you high frequency here. It means high frequency damage the base of the cochlea. Just try to learn the concept. We are having this is one is apex, that is known as helicotrema. One is a base. Now, if I draw a simple line diagram of your middle ear, this middle ear inside is your cochlea. It means if there is any trauma, any injury on the base of the cochlea, it is very close to your promontory. Is it clear? So out of 4 options, any choice which is very close to promontory will be the right answer. So in the given choice, the answer option will be C option. Is it clear? Basic anatomy. Okay, the base of the cochlea, damage in high frequency hearing loss. Clear? So high frequency hearing loss means patient working in some industry where there is a loud sound. So this MCQ can be either in this form, anatomy, or they can ask you with the ENT, with the PSM integrated question, what are the WHO guideline for noise induced hearing loss? So WHO guideline is 85 decibel is the upper limit, 8 hours in a day, 5 days in a week. So these are the important 3 points which should be on your tips. If they ask you the Indian Factory Act, that is your 90 decibel. In WHO, it is 85 decibel. Is it clear? Crystal clear. Coming to the next one, very favorite. MCQ of your NEET examiner, bronchial asthma, sinusitis, semester. His examiner is asking you about semester. So what is the basic funda? Sensitivity to aspirin. So there are two things. One is he can confuse you in writing the word resistance. देखो बेटा कैसे क्वेश्चन बनते हैं, how they make the MCQ. They will write resistance to aspirin. That is absolutely false statement. It is sensitivity to aspirin. Second, NEET 2024, they have given a statement which of the following is a false statement, and the statement given was sensitivity to aspirin alone. If they mention this word alone, again false statement. Na beta, any COX inhibitor with having the same chemical compound chemistry of aspirin will be sensitive. So I cannot write the word alone. So that is making a false statement. Is it clear? So option is D. Taking you to the next one, very important. But I try my best in the last spell. Now I have given you must-read topics. Tonsillectomy, type of hemorrhage, type of bleeding, what is primary hemorrhage, what is reactionary, what is secondary. Let's revise. Primary. What is primary? Primary is on table, OT table. So injury to the vessel and you have to ligate the vessel. What is reactionary? Reactionary is within 24 hours. And what is the cause of reactionary? You tell me, beta. It is the slippage of ligature. जो आपने ligate किया था, it slip out. You take the patient to the OT back and re-ligate the vessel. And what is secondary? Secondary is after 24 hours. After 24 hours, if any bleeding is there, we call it as secondary hemorrhage. Is it clear? What is the cause? Cause is here infection, and we go for IV antibiotics. Now let's read the MCQ. Surgery, uneventful, shifted to the recovery room. Catch in the MCQ. Recovery room. The bleeding was there in the recovery room. Means within first 24 hours, I have to shift the patient and I have to re-ligate the vessel again. Is it clear? So 2020, they have asked you the same question in different format. The question was like this: patient was discharged on the 5th day. Patient was having some chips and he was having some bleeding in the oral cavity. On examination, bleeding was coming from the tonsillar fossa. That is secondary bleed. Cause infection. Treatment IV antibiotics. Is it clear? Or they can ask you on which day secondary hemorrhage is most common. Definition more than 24 hours. But on which day it is common? It is common between 5th to 7th day. Yaad rakhenge beta. It is 5th to 7th day. Crystal clear? Clear. Question number 4. Straightforward E. coli. I hope everybody is master of this. Mnemonic. Atnaf, cochlear nucleus, olivary, lateral lemniscus, inferior colliculus, middle geniculate body, auditory cortex. Now, superior olivary complex is the third landmark. It cannot be the first one out. Rule out. Option A is ruled out. Inferior colliculus is the fifth one. It cannot be the first one out. Lateral lemniscus is the fourth one out. Right answer will be B option. Is it clear? Now on this platform, I'm giving you 3 more MCQs, but listen carefully. Cochlear implant. If the examiner asks you cochlear implant stimulate which part of the auditory pathway, that is 8 now. What is the importance of cochlear nucleus? That is brainstem implant. Brainstem implant stimulates. It stimulates which part of the auditory pathway? Brainstem implant stimulates here cochlear nucleus. Brainstem implant stimulate cochlear nucleus. Is it clear? And olivary complex. Anybody? Olivary complex is the right answer for stapedial reflux. Highest center for stapedial reflux. So with the help of this 4th MCQ, let's crack 3 more MCQs. Cochlear implant stimulate 8 now. Brainstem implant stimulate cochlear nucleus, and highest center for stapedial reflux is superior olivary complex. Superior olivary complex. Is it clear? Crystal clear. This is the whole auditory pathway I have shown you. Coming to the next one. A male in second decade, multiple bleeding. I should not read the MCQ. I will go with angiofibroma. Examiner is showing you CT with a large, ill-defined soft tissue which is filling the coin. Here the student feel it is enteroconal polyp. Not at all. It is not enteroconal polyp. It is your angiofibroma only. So diagnosis will be going in the favor of B option, that is angiofibroma. What are the other keywords? Enteroconal polyp. They will mention 10 to 14 years. Again, age group is same, but bleeding will not be there. There will be no bleeding. They will be using a word pearly white mass on examination. Pearly white mass. Mucormycosis, diabetic patient have to be there. Rhinosporiosis patient taking history of taking bath in the ponds. mulberry-like polyps, will go for rhinospoliosis. Is it clear? Angiofibroma, beta 5-6 point, no biopsy. No biopsy. Sphenopalatine foramen is the most common site. Frog face deformity and Hallman-Miller sign. These are the keywords for angiofibroma. Is it clear? So answer will be your B option, that is juvenile angiofibroma. Question number 6. A child with a history of hearing loss. What I am showing you, can you see beautiful blebs with a blebs, balloon like swelling? I will follow the flow chart if you appreciate. If you see on examination, otoscopic examination blebs, I have two possibilities. Either the patient is having hearing loss. If the patient is having hearing loss, we'll make a diagnosis of serous otitis media. Is it clear? If patient is having pain, meningitis bullosa, we call it as meningitis bullosa. Here hearing loss is a prime symptom. Tympanic membrane is not red, meningitis bullosa, it is red. I'll be going for serous otitis media. Is it clear? CSM will be the history of ear discharge. Pneumotympanum, it will not be bleb-like finding, it will be a bulging tympanic membrane. Is it clear? Last spell beta, no need of adding anything. Just try your best to rule out the option. Any option where you are feeling uncomfortable, crack that topic option. It's like, what is meningitis bullosa? If you're not aware of this point, you should be revising meningitis bullosa nicely. It is painful blebs over the tympanic membrane. Is it clear? A 50-year-old patient, tinnitus, earfulness. If I see the word earfulness, it is going in the favor of earfulness. It is going in the favor of ear Meniere's disease. Hearing loss. 7 years later, he was having vertigo, headache, progressive loss of balance. Audiometry shows sensorineural deafness. Given the slide, examiner is showing you histopath finding beta. If I remove the slide, if I remove this slide, the answer will be Meniere's. If I add the slide, answer will be vestibular schwannomas. In my MCQ, if the word Antony A N O T I, Antony A, Antony B, or ice cone appearance or rollover phenomena, out of these three, if anything is given, I will go for neural deafness, acoustic humor. Just try to appreciate this question. It is very difficult to differentiate sensory from neural. Very difficult. So if rollover phenomena given, it is your neural. Ice cone appearance given, neural. Antony, neural. So they have given you the histopath finding, that is vestibular schwannomas, ice cone appearance. I am showing you beautiful ice cone at CP angle. Remember with the ice cone appearance of middle ear. If the examiner show you ice cone appearance of middle ear, that is normal finding. That is not abnormal. That is not abnormal. This question, I think examiner is obsessed for asking this question for the last 3 years. Every examination, patient is showing you this, examiner is showing you this slide, AP view. If AP view, it is like a circle, I will be going in the favor of esophagus. So answer will be option D. Last NEET, they have asked you button battery, double ring sign. If the examiners show you double ring sign, it will be button battery. Is it clear? So this is the appearance for esophagus, and if you compare with the trachea, it will be AP view, it will be line, it will be straight line. Is it clear? Crystal clear. Done. Question number 9. Highly conceptual, all of the following are associated with given tympanogram except. So I don't know, having an idea about this investigation. I have no idea about this graph. Can you attempt the MCQ? Yes. Odd man out. Just try your best to rule out the option. Out of 4 options, I can appreciate otospongosis means otosclerosis, tympanosclerosis, tympanofibrosis. They are same. It means ossicular damage is entirely different. So very strong message. When you are not confident of the topic, try to go for odd man out theory. What is odd man out theory? Out of 4 options, ossicular disruption is the odd man. I will attempt this option. Now let's go with the concepts. This is AS tympanogram. Beta. Normal tympanogram is like this. It is hypomobile. Hypomobile will be in all the condition except ossicular damage will be getting AD graph, not AS graph. It will be AD graph. Is it clear? Crystal clear? So this is AS graph. Done. Last MCQ, 55-year-old patient with right-sided neck mass on examination, aryepiglottic fold involved. True vocal cord are mobile. Because vocal cord are mobile, I should go in the diagnosis of T1 or T2. On examination, paraglottic space invasion or multiple lymph nodes are there. Paraglottic space, it is T3. Multiple lymph node, it is 2B. Single ipsilateral is 2A. Answer should be D option. Answer should be D option. Is it clear? TNM classification should be on your tips. Management should be on your tips. What is management? Carcinoma in situ, CO2 laser. T1, T2, we go for radiotherapy. T3, T4, we go for total angectomy with radiotherapy. Is it clear, beta? So I tried my best to give you all the must-read topics. Even then, any query, just inbox me on the Insta or just update in the Telegram group. Thanks a lot for listening to me. Best wishes, beta. Best wishes.
Hello everyone, in this video we shall be discussing few questions regarding biochemistry subject which will be helping you in the NEET preparation. So let's get started. Question number 1. A 12-year-old child presents with mental retardation and has a history of self-mutilation. So it is a very easy to understand that if we are talking about self-mutilation, we are talking about Lish-Nihan syndrome. Characteristic: Lish-Nihan syndrome. Lish-Nihan is an X-linked disorder characterized by deficiency of the enzyme HGPRTase. H stands for hypoxanthine, G is for guanine phosphoribosyl transferase. This enzyme is the enzyme of salvage pathway of purine synthesis. There are two types of purine synthesis, either it is salvage or it is de novo purine synthesis. This particular enzyme is the enzyme of the salvage pathway. Now, if this enzyme is defective, then there will be increase in hypoxanthine levels and there will be increase in guanine. These two are purine in nature and hence ultimately they will become uric acid, and that is why we will see high serum uric acid in a case of Lish-Nihan syndrome. Then another question. A protein that precipitates on heating at 45 degrees Celsius and redissolves on boiling is. Now see, you might remember that in biochemistry practicals, you have done this experiment that you take a test tube and you fill this test tube with urine and then heat it. And then we will heat this test tube. Now, when you try to heat this, what will happen is, because it has protein in nature, protein will get denatured and it will become, after denaturation of protein has occurred, this will become white in color. That is what happens. But what if I heat this urine sample? It shows turbidity in between 50 to 60 or around 45 to 60 degrees of Celsius. And then you heat it to 100 degrees Celsius, it becomes clear. Now you allow this test tube to remain like that. When the temperature will start falling from 100 to 90 to 80, then again when it reaches a temperature of around 45 to 50 degree, again it shows turbidity. If that happens, that is characteristic for Bence-Jones proteins, and these are seen in cases of multiple myeloma. This is seen in case of multiple myeloma. Another question, enzyme activity is expressed as which of the following? See, you might have all heard that when we say that enzyme like ALT, AST, that the normal value is around 30 to 50 international units per liter, depending upon various labs, some say 40 to 50, some say 30 to 45. So it is expressed in international units per liter. But what are we measuring in this international units per liter? We are measuring the enzyme activity, and that enzyme activity is measured in terms of how much amount of substrate is converted to product in 1 minute if we start with 1 micromole of the substrate. So how much product will be formed in the end, and that is enzyme activity. So enzyme activity is expressed by micromoles per minute. एंजाइम ने हाउ मच काम किया है, हाउ मच एक्टिविटी इट हैज परफॉर्म, सबस्ट्रेट से कितना प्रोडक्ट हैज बीन कन्वर्टेड. देन Which of the following elements is known to influence the body's ability to handle oxidative stress? The various options are calcium, iron, potassium, selenium. Selenium particularly is required by an enzyme. It is part of this enzyme glutathione peroxidase. The function of this enzyme is to convert hydrogen peroxide to water. It will convert H2O2 to water. That means more of hydrogen peroxide is present, more are chances of becoming free radical. But if there is high activity of this enzyme, it will convert hydrogen peroxide to water, and because this enzyme is requiring selenium, it is a selenium containing enzyme. It contains selenium in it in the form of selenocysteine. So this enzyme particularly is involved in reducing the oxidative stress, or in other words, you can say this enzyme is particularly involved in maintaining the of the reducing agents in the body. So selenium is also having vitamin E sparing effect, because vitamin E out of all the vitamins is the most potent antioxidant. Another question, which of the following reaction requires vitamin K? It is gamma carboxylation. You might have heard that vitamin K is involved in the activation of factor 2, 7, 9, 10. Ideally, it should be written in Roman way. I write it like this so that it gives you a photographic memory. Now, these factors, factor 2, 7, 9 and 10, they are present in their inactive state. They are prepared, but they are inactive state. When post-translational modification will occur, now see, these are proteins, so they will have glutamic acid attached to them. So wherever glutamic acid is present, they will have one COO negative. What vitamin K does is, it adds one more COO negative, making it highly acidic in nature. This is gamma carboxylation, and this is added from, the second COO negative comes from carbon dioxide, but it is incorporated by a vitamin K dependent carboxylase. This enzyme which is adding carbon dioxide requires vitamin K, and hence what is vitamin K doing? It is doing carboxylation. Now, I leave you one question that you will find it out. There was one vitamin which is responsible for hydroxylation. It is also a post-translational modification. Find it out. Thank you for watching this video. I wish you all the best.
Hi everyone, Dr. Saurabh Sharma here. Let us see the NEET mock questions for 2025. Always I say look to those questions first which you have done wrong, and then others in a quick manner. So let us see the 10 questions. The first question is, which is true for the following picture. It's the retinoscopy values shown that after completion of retinoscopy, the vertical axis is 0 diopters and horizontal is -4 diopters. So it means that the vertical axis might be focused in front on the retina, because that's why you're giving no spectacle, no power in that, while -4 means focus of the rays might be in front of the retina, and that's why you're giving minus to diverge. So this is astigmatism, and one on the retina, one before the retina means it is simple myopic astigmatism, and you have to say which is true. So there is no astigmatism, that is false. There is astigmatism, simple myopic astigmatism, and which rule? -4 is more in front, means the cornea converging power of horizontal will be more. So horizontal is steeper, vertical is flatter. So horizontal is flatter is wrong, horizontal is steeper. That is against the rule astigmatism. So cornea curvature of horizontal will be more, that is true. And minus, even if you don't know the fourth one, you just convert. -4 diopter is 180 degree will be the refractive spectacles. Just convert this. Just try to convert this. -4 diopter at 180. Spherical is not there, so take spherical as 0, 0. -4 at 180 means it is working in vertical. So that is wrong. It is -4 in the vertical, 0 in the horizontal in this. So actually it will be -4 diopter cylinder at 90 degree is the actual refractive spectacle for this patient. But C option you could have ruled out because cornea curvature of horizontal is more, that is true statement. That is why it is with the, that is why it is against the rule astigmatism. That's why its focus is more in front of the retina. That is by definition against the rule. Now second visual field question is very important. This is always a patient's view. So this is the right visual field, this is left. And there is the bilateral defects. This is right homonymous hemianopia. Without macula sparing, macula is also involved. So this patient will be unable to see right side images from both eyes. That is true statement. Unable to see left eye images from both eyes will be left homonymous myopia. Unable to see left eye images from both eyes with the small black dot from right eye. I don't know what the author means by this. Maybe with the small black dot from the right eye. I don't know what does it mean, but answer is of course this is right homonymous myopia seen in left optic tract lesions. Okay, but black spot, if you're saying that black spot from the right eye is a blind spot, that is wrong, because blind spot is a negative scotoma. Nobody can realize. Can you realize 2 black spots in front of your eyes right now while watching this? If you can, please contact me. Now, cataract surgery complication is also very important. A patient has a eventful cataract surgery, means some complication happened, and this complication was posterior capsule rupture. That's why the doctor has to place anterior chamber IOL. Few months after surgery, patient has complaint of decreased vision with difficulty in open eyes in the morning. On examination, cornea haze was there with Desmond's folds. Now, specular microscopy is a keyword. Specular microscopy is telling about the endothelium of the cornea. That was abnormal, means something is happening to the endothelium. Ultrasound B scan was normal, so endophthalmitis ruled out because B scan should be involved, vitreous should be involved in endophthalmitis. Bullous keratopathy is actually the answer. Kera means cornea. Endothelium cell loss can lead to corneal stromal edema, and ultimately which can lead to epithelium edema of the cornea. And if there is an epithelium, there is blisters formation in the epithelium. That blisters are known as bullous keratopathy. Desmond fold cornea haze is not involved in cystal macular edema. That would be gradual decreased vision with flower petal appearance on angiography. Thickness of the retina is increasing. Posterior capsular opacification will not have any cornea haze, Desmond folds, no pain also. That is the most common complication of cataract surgery. So answer is B. Vinod. Okay. Now fundus picture is a right fundus picture. Now fundus picture is taken from fundus camera. This is not an indirect ophthalmoscopy picture. So this is the nasal, optic disc is the nasal side of the retina. This is temporal, this is superior, this is inferior. So this is the right retina. And this is marked. This is yellow. Yellow means exudate. Actually all 4 are yellow, but lipofuscin is not the answer because lipofuscin can be there in the center in Best disease like an egg yolk appearance or scattered everywhere in RP, which pictures cannot be appreciated in Stargardts. So this is small in clusters. This is not a cotton wool spot. Cotton wool spot is soft exudate, so that is ruled out. This is small in clusters, hard exudate. Now why it cannot be drusense? Because drusense is seen in age-related macular degeneration only in the central retina, not all over the retina, and not accompanied by hemorrhages. That's why the answer is small in clusters in outer plexiform layer of the retina because that is more extravascular space, hard exudates. Now diabetic female with OPD with diminution of vision, fluoresceint angiography, multiple white dots in the retina all over quadrants. Multiple white means hyperfluorescent dots. Hyperfluorescent dots in diabetic retinopathy is microaneurysm. That is the first sign of diabetic retinopathy. And this picture is shown. All these white dots are microaneurysms. Left retina is shown true. Sign is new vessel L4. Sign is microaneurysms, which is seen in the very early stages of diabetic retinopathy. Only diabetic control is needed in NPDR. Ocular treatment is required for PDR, proliferative stage of diabetic retinopathy, when there is new vessels or vitreous hemorrhage or tractional retinal detachment. Now, 20-year-old boy with complaints of decreased vision in the left eye, examination left eye cornea was clear. On looking down, there was bulging in the lower eyelid. This is Munson sign that is classically seen in keratoconus patient. Retinoscopy shows scissoring reflex. Now, two options as keratoconus. Answer is only keratoconus because in acute hydrops there will be descendant membrane rupture. Aqueous will imbibe into the cornea, causing pain, corneal edema in keratoconus. Here there is nothing history, so answer is keratoconus. Munson sign is there in keratoconus. A child with acute pain, full proptosis rules out limbal dermoid, which is not a differential. Answer is limbal dermoid because limbal dermoid is painless condition. Orbital cellulitis is painful. Rhabdomyosarcoma is a most common malignant tumor in the orbit, causing pale film proptosis, descendant positivity. And chocolate cells, even if you don't know, you should know dermoid is painless. Most common benign tumor in the orbit. And of course, limbal dermoid, dermoid is cholestoma, normal tissue in abnormal place, but no pain. And chocolate cell is actually ruptured lymphangioma. Lymphangioma is painless, but ruptured lymphangioma can cause pain. Even dermoid is painless, but ruptured dermoid can spill keratin in the orbit that can cause pain, which is not written here. That's why limbal dermoid is the only answer over here in which pain is not there. And even proptosis is not there. Proptosis will be there in orbital dermoid. Limbal having dermoid will not cause proptosis. Orbit dermoid will cause proptosis. Now, which is false when a patient is asked to do this? Patient is asked to do levo depression. This is the type of version. Levo depression. It is a type of version. Herring's law works here, not Sherrington law. That's the answer. And if you know the light diagram, this muscle and this muscle works. This muscle is right SO. This is left IR. Right SO and left IR are tested here. And in complete third nerve palsy, left third nerve palsy, the patient will not have diplopia in this case. Because in left third nerve palsy, what will happen? The left eye, right eye in the center, left eye will be down and out. Down because of SO, out because of LR. In levo depression, there will be no diplopia because both eyes will be aligned to each other. So that is also true statement. But you should know Herring's law applies in version. Sherrington law tells about antagonism, which determines the direction of squint. Sherrington law. Now, see a patient in ICU after cardiac bypass, right pupil is dilated and unreacted to light, and it was observed he is having right third nerve palsy. Now, when the light shown in the left eye, the right pupil, what will be observed if you have right third nerve palsy? So now the patient has right third nerve palsy, means right eye is having ptosis, down and out eye, left is looking straight. Now, what will observe if you have right third nerve palsy? When the light shines on the left eye, let us see. When you shine light in the left eye, left second nerve will take the impulse and left third nerve will take the impulse. Right third nerve cannot because that is paralyzed. So left will constrict, right will not constrict. Answer A is wrong. When the light shines on the right eye, when you throw light in the right eye, right cannot constrict. Left will constrict because right second nerve and left third nerve are okay. So let us see, when you shine the light in the right eye, left pupil constrict. That is a true statement. But let us confirm. When the light shine on the right eye, the right pupil constrict. That is wrong. And when the light shines on the left eye, neither pupil constrict. That is wrong. Actually, in third nerve palsy, you throw the light in any eye. Affected pupil does not constrict. The fellow eye will definitely constrict. You throw light in any eye, answer will be same. Affected pupil does not constrict. Now the last question, a patient presented with bulging right eye. Bulging means there is proptosis, restriction of right eye movements, ophthalmoplegia. So bulging, proptosis, ophthalmoplegia, corneal sensations are decreased. Means third nerve palsy, fourth nerve palsy, sixth nerve because of ophthalmoplegia. Proptosis is there and V1 nasociliary is involved. Now left eye had no bulging, but there was limitation in abduction of the left eye. Means something is going to the other side, and that is possible only when there is a orbit problem which is going to the opposite side via cavernous sinus. And in the cavernous sinus in the medial wall, the sixth nerve is in the medial wall. So right eye there is cavernous sinus syndrome. Third nerve, fourth nerve, even V1, V2 can be involved. So loss of cheek sensation can be there. And the other side is going that rules out SOF and orbital apex because that is always unilateral condition. And the other side, 6 nerve in the medial, 6 nerve supplies lateral rectus, which causes loss of abduction in the other eye. That's the first sign of bilaterality in the cavernous sinus. Pseudotumor is a idiopathic inflammation of the orbit tissues. It has to be differentiated from thyroid eye disease. But in thyroid eye disease, the only muscle of the belly is involved, tendons are spared. In pseudotumor, the muscle and belly both are involved. That's a radiology question. Some Coca-Cola bottle sign is there in thyroid eye disease, only muscle of the belly of the muscle is involved, tendons are spared. Here the answer is, it is going to the opposite side, that is cavernous sinus. That's the 10 questions. I hope you have done well. If any doubts, you can ask me anytime, on Telegram, anywhere. Thanks a lot. Best of luck. Do well in the exam.
Let us discuss the questions which came in NEET PG mock this year in this test. So the first question is, we have a 12-year-old boy who presented with a 3-month history of asymptomatic axillary rash that fluctuated in severity but never got cleared. He was otherwise normal. What other test can be done to look for the diagnosis? So please remember, bacho, that this is a patient with a very classical lesion which is known as erythrasma. And this is a Corynebacteria minutissimum infection which presented with hyperpigmentation on the flexures. We have to do Wood's lamp examination to see the coral red or coral pink fluorescence. Wood lamp is actually a very small handheld instrument which help us, it help us know about the conditions without doing an invasive test of biopsy. So Wood's lamp emit UV rays, and all those objects or all those organisms which have this capacity of having a fluorescence, they absorb the UV rays and they emit a light of a longer wavelength. So the organisms like erythrasma, Corynebacteria minutissimum, then we have Malassezia of Pityriasis versicolor, Microsporum of Tinea capitis, they all have this capacity to emit the wavelength, longer wavelength. So the answer of this question is number 1. So the patient of erythrasma which occur due to the Corynebacteria minutissimum, the organism has the property of fluorescence, and hence when seen under the Wood's lamp it shows characteristic coral red and coral pink fluorescence. Follicular hyperkeratosis, it is nothing but phrinoderma, that's a feature of vitamin A deficiency. When you have vitamin A deficiency, there is dryness, and slowly this dryness progress and they start having some follicular prominences on the elbow, knee and the buttocks. So this is a phrinoderma and feature of vitamin A deficiency. Allergens responsible for this condition, this is actually nothing but the hair dye. Patient has applied hair dye and following which he has allergic contact dermatitis. The allergen in the hair dye is paraphenyl diamine. So this is a patient of allergic contact dermatitis to hair dye and the allergen is PPD. Now this is a patch test which is actually the investigation of choice for contact dermatitis. It is based on type 4 hypersensitivity reaction. Okay, so it is based on type 4 hypersensitivity reaction. The patients who are the patients of allergic contact dermatitis, they have memory T cells, and whenever they are re-exposed to the same allergen, even if a minor quantity of it is exposed, it will present with a similar presentations. Now it is a patch test, the investigation of choice for allergic contact dermatitis, and it's a type 4 hypersensitivity reaction. Farmer has a black mole on the cheek, increasing in size, they become irregular and invade deep. So please remember, bacho, there are 2 ways a malignant melanoma can progress. One is the cancer cell just infiltrate horizontally, and the other one is the cancer cell goes more deep like this. So these are the 2 ways. So the horizontal progress is seen in the acral type, lenticomaligna, and superficial type, while the deep growth is seen in nodular melanoma type of malignancy, melanoma. So these were some of the questions. The deeper spread is actually the feature of the nodular melanoma. So these are some of the questions which you got in the recent mock exam. Thank you.
Yes, so a very good afternoon everyone. I am here to discuss some questions of the NEET PG mock exam of physiology. So the first question was, a 37-year-old woman is found comatose in her kitchen by her husband and taken to the emergency of the nearby hospital. Blood gas analysis reveals normal PO2, lower than normal arterial oxygen saturation. Which of the following conditions is most consistent with her findings? So remember, anemia will not be the answer, because in anemia the arterial O2 is normal. You all know that, yes. But please remember, the oxygen hemoglobin saturation will also be normal. Oxygen hemoglobin saturation percentage will also be normal, right? But oxygen content can be decreased. Here the oxygen hemoglobin saturation is given as less. This is the case of CO poisoning, which remember causes anemic hypoxia. Why? Because arterial O2 is normal again, but carbon monoxide binds with 210 times more affinity to the heme than oxygen, thereby decreasing the oxygen hemoglobin saturation, right? So read up the question again. There is lower than normal arterial oxygen saturation. Also remember, carbon monoxide causes left shift of the oxygen hemoglobin dissociation curve, because it decreases the glycolysis, thereby decreasing the 2,3-DPG. Hypoventilation would naturally cause decrease in arterial O2, so cannot be the answer. Low VQ ratio will also lead to decreased PO2, cannot be the answer. Anemia I have ruled out for you, so the only correct answer is carbon monoxide poisoning. Given below are 4 examples of transport across the cell membrane with the type of transport. Which of the following is incorrect? Transport of glucose from the intestinal lumen into intestinal epithelial cell is by facilitated diffusion. Yes. Is it correct? Please remember, this is intestinal lumen. This is the transporter. If you recap for me, sodium, glucose. This is SGLT1. So this is secondary active, right? Secondary active. So please remember, this is actually incorrect. But transport of glucose into adipocytes, absolutely correct. GLUT4, this is true. Movement of calcium from cardiac muscle cell to ECF is by sodium dependent counter transport. Yes. NCX, sodium calcium exchanger. 3 sodium calcium exchanger. Movement of sodium into the nerve cell during upstroke phases by simple diffusion. That's true. Any movement of sodium or the potassium, any ion through the ion channels is always simple diffusion, right? Moving on to the question number 3. True about baroreceptor reflex is from the carotid body and aortic body. No. These are your chemoreceptors. Causes arterial vasoconstriction when BP increases. Remember, if your blood pressure increases, I will reduce the sympathetic nervous stimulation. I will do arterial vasodilation. So this is false. Causes increase in heart rate when BP increases. Remember, if the BP is increased, sympathetic nervous stimulation will decrease, heart rate will decrease. So this is wrong again. Causes decrease in heart rate when BP increases. Absolutely correct, right? Absolutely right. Moving on to question 4. Which of the following will be found in a dehydrated individual deprived of water for 24 hours? Remember, this would cause huge increase in osmolarity. Plasma osmolarity increases, right? So dehydrated individual, increased fluid loss. Remember, this would stimulate RAS. So plasma renin activity will be increased. This would increase the ADH because osmolarity increase. Plasma osmolarity is the most potent stimulus for ADH release. Increase plasma ANP. Atrial natriuretic peptide increases whenever there is more atrial stretching. In case of more atrial filling, more blood volume, so this would be decreased. Increase water permeability of the collecting duct. Absolutely correct, because remember, more ADH will cause increase water reabsorption 13 to 15% in the principal cells of the collecting duct. Please remember that. That is absolutely correct. So moving on to the last one here, the following diagram shows the changes in hypothalamic set point and body temperature during fever. Which of the following hypothalamic nuclei will be activated at point B as compared to point A, or in with respect to point A? Let's recap. Let me zoom the picture. Please see here. As soon as the set point rises suddenly to high value, what will happen? I will try to match the set point. So at point A, remember, I am doing more shivering. I am doing more vasoconstriction. Which hypothalamic nuclei will be activated? Yes, which one? Think about it. Posterior hypothalamus. Then because of the either doing, giving antipyretics or during the normal course of fever, there is a sudden drop in the set point. Now I am going to do more of vasodilation and sweating. This would be done by which hypothalamus? This would be done by, yes, which one? Yes, remember, anterior. And please remember, preoptic nuclei is a part of anterior hypothalamus. Preoptic nuclei is a part of anterior. So let's go back to the options now. What will happen at point B? Vasodilation, sweating. The answer is none other than anterior, right? So no confusions here. Most of you should have got the answer correct. Remember, ventrolateral is mainly for feeding, hunger, or thirst center. Ventromedial, satiety, right? Reward, satiety. So I hope all of you got at least 4 out of 5 correct, and some of you should have got the entire 5 correct, right? Best wishes from my side for the upcoming exam. God bless you all. Do your best. Leave rest to Almighty. Take care.
Hello friends, let's discuss the questions that you gave in your mock, and I hope all of you gave this mock, and we have tried to emulate the type of questions that are commonly asked in the exam, the pattern and the level of the exam. So the 65-year-old male with a stable COPD presents with mild hypoxia, that is SpO2 92% in the emergency department. He is alert and has no respiratory distress and is hemodynamically stable. The decision is made to provide supplemental oxygen via nasal cannula. What is the maximum flow rate at which the nasal cannula can effectively deliver oxygen before significant patient discomfort and nasal dryness? So this is basically asking you at what is the maximum level of O2 flow rate that you can use on nasal cannula, and we know it works between 1 to 6 liter per minute, because if you go more than 6 liters per minute, then it can cause nasal dryness and nasal crusting. And every O2 delivery device has to work at a very specific flow rate. So we kind of consider that specific flow rate and we act according to that. So it is 6 liters per minute. Concerning etomidate, it has analgesic properties. Hypnosis can occur through NMDA receptor. Etomidate can lead to pain during injection, and etomidate is a myocardial depressant. So whenever I give you a question like this, my idea is not only that you will mark the correct answer, but also to know more about the drug. So if the question is true about etomidate and you know that it causes maximum pain during injection, that means you also get to know 4 more properties that no, it is not analgesic. Analgesic property is seen with ketamine. No, it doesn't act through NMDA receptor. That is a property of ketamine. Here it is GABA agonist. And no, it is not a myocardial depressant. It is actually a myocardial. It is something which is a cardiostable drug. Cardiostable agent. Alright. So it is a cardiostable agent. So you not only get to know that's one right property, which is the answer to your question, but also 3 more properties. So in general, you revise 4 more properties of that drug. Regarding bispectral index, BIS, it can distinguish between the causes of decreased brain activity. It requires expert interpretation, predicts movement to surgical stimulus, and higher values represent more cortical activity. So let's first talk about BIS. And I hope that you never make a mistake that BIS is not an abbreviation. So it is not, doesn't stand for bispectral index, spectrography, or spectrometry, or scale. It is just the first 3 letters of the word BIS. So one is that it is not an abbreviation. Second, it is a depth of anesthesia monitor. It is a depth of anesthesia monitor, right? And it measures that by processing the frontal EEG. It does it by frontal processed EEG. So can it differentiate between the causes of decreased brain activity? No, because it is just a number which is telling you about the brain activity. Does it require expert interpretation? Definitely no. It doesn't require expert interpretation, and that is why it's such a great, because all you have to do is interpret the numbers. Does it predict movement to surgical stimulus? Even if the patient has a good depth of anesthesia and not so good muscle relaxation, the patient can have movement. So it is not something that predicts the movement. And does higher values represent more cortical activity? Yes, that is why 80 to 100 is an awake individual. And when you have patient with 60 to 80, that is mild sedation, and 40 to 60 is the level required for adequate GA. So when I look at a number 50, I know it is less cortical activity. That is why I say it is anesthesia. All right. Question number 4. Now, metabolism of local anesthetics depend on the chemical structure. Which of the following statements about the same are true? Amide local anesthetics are rapidly metabolized by plasma cholinesterase. Metabolism of bupivacaine is independent of hepatic function. Ester local anesthetics are rapidly metabolized in the kidneys, and metabolites from ester hydrolysis are excreted in urine. Metabolites from ester hydrolysis are excreted in urine. So we know based on chemical structure of the intermediate chain, you have 2 types of local anesthetics. Amides and ester. Now, do amide local anesthetic get rapidly metabolized by plasma cholinesterase? No, that is the property of ester. So this is false. Metabolism of bupivacaine is independent of hepatic function. No, amide are metabolized by liver. So they are not independent. Ester local anesthetic rapidly metabolized by kidney. No, they are excreted by kidney. And metabolites from ester hydrolysis are excreted in urine. Yes, metabolites from all are excreted by urine. What is the compression to ventilation ratio you should use when giving CPR to an infant who is 2-year-old when 2 rescuers are present? When 2 rescuers are present. So this is where you have a point of opinion that when you have compression to ventilation ratio, and if it is asked in terms of how it is going to be. So if it is an adult irrespective of number of rescuer, it is always 30:2. So 30 compressions and 2 breath. In a child, which can be infant or a child, it depends on the number of rescuer. If you have 1 or 2, 1 is again 30:2 and 2 is 15:2, because most common causes of cardiac arrest in a pediatric age group is respiratory rather than cardiac. So it is always better to increase the number of breaths as compared to compression. So the correct answer is 15:2. So these were the 5 questions that I wanted to discuss in your mock, and I hope that you are on track with your studies, and I hope to see you soon on the other side. Thank you.
NEET Mock 2025 Psychiatry Questions Discussion. There are 5 questions in this paper that have been given. I suppose you have attempted the paper before listening to this video. The first question is a PYQ. Why did I give this question? Because delirium versus dementia has been asked 3 times. We all know that delirium is acute, dementia is chronic. We all know delirium is fluctuating, dementia is progressive. We all know delirium has altered sensorium and dementia has clear sensorium. And we all know that delirium has remote memory normal. So these are the 4 major differences which most of us know about. And most of us already knew that the best to differentiate is altered sensorium. Best to differentiate from delirium versus dementia is altered sensorium. Dementia is chronic, progressive, clear sensorium, this is the difference between delirium and dementia. I am counting on this question for this NEET PG as well. Very simple, very basic question. Delirium is acute, dementia is chronic. Delirium is fluctuating, dementia is progressive. Delirium is altered sensorium, dementia is clear sensorium. Delirium is remote memory normal, dementia is remote memory lost. But the best to differentiate is this, but this was not in this question. So the second best to differentiate is fluctuating course. The second best after sensorium is fluctuating course. Please remember this. The fluctuation in the level of consciousness in delirium as compared to normal conscious in dementia. Remember this. Now this question is here to tell you sometime old AIMS question are also asked as a PYQ in NEET. Old AIMS question. It's an old AIMS question. I'm not sure whether all of you have read the AIMS PYQ. A patient presents with colicky abdominal pain with behavioral abnormality. And you check for weakness in the form of neuropathy. This qualifies for the criteria of AIP. Acute intermittent porphyria. Usually my patient would not have pain. If a psychosis patient has abdominal pain, I look for the signs of weakness, neuropathy. If weakness, colicky pain and abnormal behavior come, this is the triad of acute intermittent porphyria. This is how we suspect porphyria. So every patient of psychosis having pain abdomen, we suggest suspecting porphyria, urine for porphobilinogen. If it is positive, it is porphyria. Acute intermittent porphyria. Question number 3. Which of the following is not a part of DSM-5 diagnostic criteria of ADHD? DSM-5 diagnostic criteria, onset of the symptom must be before 12 years of age, not before 7 years of age. It is a wrong statement. Onset must be before 12 years of age. Pronominal reversal. Now this is a new question for you. Out of 5 questions in NEET, expect 4 studied questions and 1 question may or may not be new. If it is a new question in psychiatry, you can attempt it like this. Pronominal reversal is a speech finding, reversing the pronouns. My name is Rahul. And I want food. This is how a normal child will say. My name is Rahul and I want food. This child will say, my name is Rahul. You want food. So he replaced I to you. This is called pronominal reversal, seen in a patient of autism. Seen in a patient of autism. Pronominal reversal. Pronominal reversal. Schizophrenia has loss of association, neologism. Dementia, we will have slow speech. Depression will also have slow speech. Last question, PYQ. The term minimal brain dysfunction. In the same NEET, they asked what is the new name of mental retardation. Answer was intellectual disability. In the same NEET, they asked minimal brain dysfunction is the name of. Answer ADHD. These two questions were asked in the same NEET itself. You are supposed to know alternative names in psychiatry. Alternative names. Hypochondriasis is also known as illness anxiety disorder. Dementia is also known as major neurocognitive disorder. Somatization is also known as bodily distress disorder. You have to know the alternative names in psychiatry. Conversion is also known as functional neurological symptom disorder. Conversion is also known as functional neurological symptom disorder. Okay. So that is all about this mock test discussion. I hope it was helpful. Wish you all the best for your upcoming NEET PG exam. That was all from Dr. Sachin Arora. Thank you. Bye bye. Thank you.
Alright, hello everyone. Let's start the discussion of orthopedics questions. So which of the following is false regarding hip dislocation?
See, when we talk about hip dislocation, you need to understand we are talking about posterior hip dislocation, anterior hip dislocation. Posterior hip dislocation, the limb goes in feather. Anterior hip dislocation, it goes in fiber. When we talk about most common complication for both of them, it is avascular necrosis. When we talk about most common nerve injury for posterior, it is sciatic nerve. For anterior, it is femoral nerve. Now, please understand, in posterior, nerve injury is more than arterial injury. In anterior, arterial injury is more than nerve injury. Now, which of the following is false? So, posterior dislocation has flexion adduction, true. Vessel injury is more common in anterior, true. Nerve injury is more common in anterior, false. Nerve injury is more common in posterior. Posterior is more common in anterior, true. C. Indicators of bone formation are all of the following except C. Osteocalcin, osteonectin are the indicator of bone formation, right. Alkaline phosphatase is also a marker of bone formation. Type 1 collagen is the most abundant collagen. Deoxypyridinoline, pyridinoline, hydroxyproline, all these things are markers of bone resorption, so D is the answer. Now, in this question, what I want you to understand is a very simple thing, that anterior cruciate ligament as a ligament further has got two bundle. One is called as anteromedial bundle, other one is called as posterolateral bundle. Now, what you need to understand is this, that when your knee is in 90-degree flexion, this is the chief bundle, tight bundle, major bundle, working bundle. When your knee is in complete extension, then this is the chief bundle, tight bundle, major bundle, working bundle. So what it says, that there is a feeling of sudden giving way of knee joint with the knee in 90-degree flexion. So when your knee is in 90-degree flexion and there's a feeling of giving way, which bundle is gone? AM. But that disappear when knee is taken into complete extension. So whose job is this? PL. So that means PL is intact, AM is gone. So answer is AM or PL? AM. Now moving over to this question. So 7-year-old boy, orthopedic, dull aching pain, inability to squat, intense pain, treated conservatively, raised ESR, other counts normal, X-ray osteopenia, mild erosion on the hip joint. Till now, whatever you have read looks amazing for Perthes, but now this is the game changer. So this is the game changer thing towards acetabulum. So basically, this is the game changer thing towards acetabulum, because early acetabular involvement is a feature of Perthes. Is a feature of TB. Late acetabular involvement is basically a feature of Perthes. So here the signs are more towards acetabulum, so answer has to be TB. Now, in supracondylar fracture humerus, this can be seen, this can be seen, this can be seen. I'm sure everybody knows about cubitus varus. I'm sure everybody knows about gunstock deformity, but non-union is not a complication that is seen in lateral condyle humerus. So with this, we come towards the end of this discussion. I wish you guys all the best. Thank you.